Anjana or Varsha. Yeah. Dr. Anjana ma'am.
Hello.
Yeah, please start.
Good afternoon, everyone. Now, hello.
Yeah, we can hear you. Should I begin?
Yes, ma'am, please go ahead.
Yes. Good evening, ladies and gentlemen. It gives me great pleasure to welcome you for this final certificate course for the year. We've had a very, very successful year with many certificate courses ranging from varied topics like postpartum hemorrhage, fertility, cosmetic gynecology, and menopause. And this is our last certificate course before the new team takes over at the AICOG in January. My thanks to Dr. Jaideep Tank for being really very, very encouraging and supportive indeed, and to Dr. Madhuri Patel for all her help. Our entire ICOG team, Dr. Parul Kurdawala, Dr. Sheila Mane, Dr. Parag Biniwale, it's been a pleasure working in the ICOG this year. Our series conveners, Dr. Parag Biniwale and Dr. Charmila, I can't thank them enough for course after course they have curated and looked after the proceedings. This time we have three very dynamic ladies as our conveners. And I'd like to thank Dr. Sarita Shamsundar, Dr. Priya Ganesh, and Dr. Anjana Chauhan, leading women in the area of gynec oncology, who have actually made the course, designed the course, arranged the speakers, decided the topics, and now are carrying it out. We have very, very able coordinators, Dr. Nilanchali, Dr. Varsha Prapanna, and thank you to them. I'm delighted that we have with us our chief guest, Dr. Usha Saraya, who's a pioneer of gynec oncology in this field and has done a lot of work in this area. And I'm really very thankful to have with us Dr. Mandakini Meg, who's been the champion of ICOG webinars. And really, she has explored this field and taken ICOG to all over the country with her webinars during the COVID period. A big thank you to all our faculty, speakers, and chairpersons. I know that it's quite a task to leave your clinical practice and do this academic pursuits. And thank you on behalf of ICOG. And a big thank you to all the delegates who are sitting with us for 3 consecutive days in the evenings. Before I end, I take this opportunity to invite you all to AICOG 2025 in Mumbai. We promise to give you a great time. It's going to be a wonderful event. And I also invite everyone who are not fellows of ICOG to please do join ICOG. Our next fellowship convocation after Mumbai is going to be in March in Pune. And you can go online and fill out the form and be there in Mumbai. So thank you very much, and I wish this today all the very best.
Thank you, Dr. Sarita. And now we'll keep our ball rolling, and none other than Dr. Usha Saraya to give her blessings. Now, this slide which is there regarding Dr. Usha Saraya is a very small. She's such a huge personality. This introduction is very small for her. She's an epitome of gynec cancer screening in India. Ma'am, you are the beginner of doing a colposcopy in India, and lots of people are trained under you. And these words which are written, it's very, very small for you. And ma'am, it will be a great privilege to give us blessings on this occasion. And I wish Dr. Usha Saraya will keep on blessing us and giving us guidance throughout our life. Thank you, ma'am. Please, ma'am, the stage is yours.
Thank you so much. And can you hear me clearly?
Yes, ma'am.
Yes, thanks. First of all, I thank you for this invitation to participate in this wonderful program. And I'm so glad that ICOG is doing these short courses to upgrade the knowledge and of our FOXY members. And these special subjects are sometimes not covered by all the teaching hospitals and the teaching programs of the PGs. So it helps them a lot. And the benefit of acquiring this knowledge will definitely translate into better clinical practice. So the eventual beneficiaries of all this exercise done by FOXY ICOG faculties, organization of courses will eventually benefit our patient population. And that is our ultimate goal. Today's discussions, we are going to cover endometrial and vulval lesions. Again, these are lesions which are showing an increase in incidence, and they're also happening at a little earlier age. And our excellent faculty will enlighten you about all these factors and point out to you how you can benefit your patients by being aware yourself and how to use the diagnostic modalities. And there is so much development in all these things that it is difficult for everyone to keep aware of this. Amongst the faculty, I'm happy to see Dr. Ava Desai, whom I've known also for many years. She's also a pioneer of gynec oncology in India. And I know this Gujarat Institute of Ahmedabad for many years. I've been going there and I've seen how well they have developed gynec oncology. So I would like to say that a little bit about the vulval lesions, because that's really a neglected organ and not everybody is coming forth with lesions on the vulva early enough for us to do something. And we now clearly know that there are some are HPV related and some are HPV independent. So that is very important to find out. And now the tests are available, so it should be easy. Secondly, the immunohistochemistry which is available to us gives us much more information, because we come to know not only accurately the HPV infection, but we also come to know at what stage of the disease the patient is and what is her immunological response to the infection. So all this information will help us to plan treatment so that we don't do either under treatment or over treatment. And when I say we create awareness amongst patients to come early and to be aware of things, I also mean that we cannot afford to frighten them. So our motto is enlighten, but don't frighten. And we would like our patients to realize that there is no end to gynec checkup. That it's nothing like after this age, you don't need to see a gynecologist. All through, you should be going for a gynec checkup and discussing your complaints with friends. So much research is going on, and it's so difficult to keep in touch with the information available. So let me congratulate ICOG FOXY for keeping all the members updated with information. And this whole thing depends on the students, how motivated they are and how keen they are to learn. And I would like to wish them all the best. And remember, there is again no end to one's learning. And eventually, after attending courses like this, your aim should be that you would like to be on the faculty at some stage. And ICOG will be your platform to do all that. So let me wish everyone good luck, and hope you enjoy the program, and hope to see you again at AICOG. As you said, we have got a whole one-day session on gynec oncology workshop and a half day of committee workshop. So there is a lot to learn even at AICOG. And thank you once again to the organizers for giving me the opportunity to be a part of this program. Thank you so much.
Thank you, ma'am, for your very inspiring words, and we always wish you keep on blessing us. Now, I invite our guest of honor, Dr. Mandakini Meg,
I think she needs to be unmuted.
to give us some of her blessings. And ma'am is also a very pioneer or epitome in working in the gynec field, and she had been a chairperson of ICOG Foxy from 2020,
It's okay.
2021, and she
It's
had
okay.
lots of laurels. If I go and speak, I think so my the time will go in that. So,
So, good
Dr.
evening. Yeah. So, good evening, everyone.
Man-
Our chief guest, Dr. Usha Saraya, Madam, Secretary, Dr. Sarita Bhalerao, President, Chairperson, Dr. Parul Kotadwala. I can see all the eminent faculties here. And Sarita, thank you very much for inviting me for such a, important certificate course. And I'm quite I can say I am a proud mother who has actually, started this online ICOG courses for 3 days. And I can see the baby growing, blooming, and you are doing excellent work. When we started as the ICOG chairperson, there were only 11 courses. And later on, you added so many. And oncology is one of the, Madam has said, oncology is one of the main, branches where you really will like to, enhance your knowledge and be, updated for all the courses. I think we have done HPV, Priya Ganeshan, all those conveners, they have done excellent job. As a AMWA president also, because we have Madam and we have Sarita and everyone here, that we are having this cytology clinic in under AMWA Mumbai branch at Kama Hospital. And since last 45 years, continuously under the patronage of Dr. Usha Saraya and all the Mumbai people, we are training people, colposcopy in every, I think Priya will, agree with me that we are her students and we are actually, keeping updated because of the courses. So, Sarita, I can see a beautiful program here. I will not take much of the time, but congratulations for, having more and more subjects in the like a plastic surgery, cosmetology, and baby is blooming and ICU is doing a great work. With these words, I really want to thank you and all the best for this beautiful program and very useful program for the students. Thank you.
Thank you, Dr. Mandakini. It was a very nice, ma'am, your gesture for our and a good blessings for our last day of the ICOG certificate course on oncology. With this short note, let us now move forward, and I will be giving the introduction of the program today. Yesterday's session revision. Yesterday was a very nice program conducted by under the under the Dr. Priya Ganesh, and she did a very nice, what we can say, there were lectures on cervical cancer screening, pap smear, HPV, and there was a very good panel discussion. And that was also done an excellent job. And so it was a nice, and more than 200 people attended it. Today's topic is on carcinoma body of uterus and vulva. As Madam Usha Saraya said, vulval tumors are evolving. Both these cancers are evolving. 25 years back, when I was in GCRI, I used to know that when Dr. Avadesai was my teacher, what we had in carcinoma body was hysterectomy, oophorectomy, and some radiation. Then 10 years back, later came the para-aortic node dissection, pelvic node dissection, and it was a huge thing. You'd have to do a para-aortic and pelvic, and there was a radiotherapy and chemotherapy. And now you have that small baby of carcinoma body has bloomed into a huge man, and there is a molecular classification, and there is tailored therapy, and there's a target therapy and radiation and chemotherapy. And for carcinoma vulva, it was a butterfly technique and 3 incision, and now sentinel nodes. We have a very good faculties for that. And vulval lesions, which is the most neglected part, as said by Dr. Usha Saraya, the gynecologists don't want to look at the vulva. They do direct TBS. Many of them do that way, and the skin specialists are never trained in vulval lesions, and they had been treated with pottery and cryo and everything, and they come with a florid disease. So with all this background, I invite all my faculties, Dr. Avadesa, she is my teacher and she is my mentor, and my colleagues Parisima Ben, Dr. Dilip, Dr. Limbachia, and Dr. Harshad. And for vulval lesions, we have Dr. Sundari from Bangalore. She's an excellent person, and I have learned many things from her. So we have a nice panelists of vulva. With this, I invite my coordinators, Dr. Varsha. See, Baroda is always known for dynamic women, and Dr. Varsha is one of them. She is a midlife practitioner, and she is a very good, I think so, as a orator, a speaker, and a quiz master. I think she's like Amitabh Bachchan to our family. Over to you, Dr. Varsha and Dr. Sapna, who is also budding from Baroda. Thank you. Dr. Varsha, you can now take over from
Yeah,
here.
yeah. Thank you. Thank you. We proceeded a little fast. I think we should be showing Dr. Sarita Bhalerao in your PPT, CV PPT. If it is possible, can we show it, Nilima? Can we have Dr. Anjana Chauhan's PPT? I want to introduce her to the delegates and also Dr. Sarita Bhalerao. Otherwise, we proceed for the pre-test. Yeah. So, Dr. Anjana Chauhan, everybody has heard, she's the series convener for today. She is preventive gynec oncologist.
Okay, then I will do that. Huh?
Yeah. And she's ex-associate professor GCRI Ahmedabad. She's chairperson Oncology Committee of Indian Menopause Society, and she's past president of Ahmedabad Menopause Society. And something remarkable about her, I want to tell everybody, she is the initiator of the first of its kind in India, HPV clinic and HPV awareness in Gujarat. The rest of it you have heard from her own mouth. And so one slide for Dr. Sarita Bhalera also. Can someone do it? uh, so we heard her already. She said so many things, but still officially I must tell all the delegates she is secretary of ICOG. She is chair West Zone India Representative Committee RCOG. She was joint secretary of FOXY 2017, quiz committee chairperson 2009 to 11, and past chapter secretary Indian Menopause Society Mumbai chapter. We have all seen she has worked very hard to carry out this prestigious FOXY ICOG Oncology webinar, a certificate course in a digital way, which has been progressing very nicely. And thank you, Dr. Sarita, for the start of the ceremony. We move further for the pre-test. It will be of 10 minutes. It will be online.
The link will be given in the chat box.
Yeah. I think it will start at 4:20, it was mentioned. All the delegates will have to scan this QR code. Then you get the set of questions. Pre-test is only of 10 minutes. I think already 2 minutes are over. Delegates, please take this pre-test and post-test seriously because there is an eligibility criteria. 50% marks in post-test on all 3 days will ensure you a certificate, and you should be a Foxy member. Only those are eligible. Okay, so we move further with this wonderful background about the prestigious Foxy ICOG online certificate course on oncology, pearls of wisdom from our esteemed chief guest and guest of honor. We move further towards the scientific session on the first session on endometrial cancer, for which I invite chairpersons Dr. Mitra Saxena and Dr. Abha Rani Sinha. Dr. Mitra Saxena is a chairperson for Practical Obstetrics Committee Foxy 21 to 24. She is editor Foxy Focus Life Saving Emergency Obstetric Surgeries 2023. She is convener Foxy GCPR on birth after cesarean sections. She has many awards to her credit. To name a few: Foxy Dhira Award 22, Foxy President's Appreciation Award 2023. She has conducted state-level conferences and hands-on workshop on ultrasound, colposcopy, medico-legal issues. I've heard you many times in past webinars during our COVID times. So welcome, Dr. Mitra Saxena. I also welcome Dr. Abha Rani Sinha to chair this session. Dr. Sinha is head of the gynec department at SKMC, Muzaffarpur. She is Vice President Foxy Elect 2026. She has been ICOG Governing Council member 21 to 23. She was President of Patna Gynec Society 2017-18. And she has UG/PG teaching experience of 28 years. And obviously, she'll be having lots and lots of publication in national and international journals. So welcome you both as to chair this first session. There is a change. We are going to have Dr. Harshad Parasni's talk first. This is information for the chairpersons, followed by Dr. Ava Desai. Since Dr. Sarita is busy with a surgery, she will follow. So over to you, Dr. Mitra and Dr. Abha Rani.
A very good evening to all the people who have logged in to attend this wonderful online certification course. And actually, thank you to ICOG, Dr. Parul and Dr. Sarita to keep us in mind to chair a session. And actually, it's a self-serving exercise because we accept the invitations because we know the topics are so good, so informative, and so well covered by our esteemed faculty that it's a pleasure to learn the latest. So just like an obstetrician can have any emergency, so instead of going on in the sequence which was prescribed, we are going to first take up the talk on molecular basis of endometrial carcinoma, which has been taken by Dr. Harshad Parasnis. Sir is a very renowned teacher, consultant gynecologic oncologist in Pune, head of gynec oncology unit and associate professor in Bharati Medical College, Pune. Also visiting gynecologic oncologist to BTMC and Sassoon General Hospital, Pune, and Ruby Hall Clinic in Pune. He has been the president of Pune OB-GYN Society, chairperson of Oncology Committee in Foxy and EMOGS, and I'm sure with Dr. Harshad Parasnis there to tell us about maybe, you know, it is divine intervention that you are going to start at the molecular level first, and then we'll come on to the next part of the managing endometrial cancer and the clinical evaluation, etc. Over to you, Dr. Parasnis.
Yeah.
The stage is all yours.
Thank you for the kind words. I'll just try first to share my presentation.
And also my regards to all my organizers and Dr. Abha Rani and Dr. Ava Desai. I'm seeing you digitally after years. When I saw that you are going to be in the same program, I was extremely delighted. I don't know whether you remember some person from the audience asking you questions. And namaste to Madam Dr. Usha.
I'm having some problem in 1 minute. I'll just sort it out. Just give me a minute. I think I'm having a problem trying to share my file.
Terry, have you opened your PPT?
Yeah, I've opened my PPT. That's why.
Okay, Dr. Surjit, we are all here. We're just waiting for Dr. Harshad to get his presentation to open. Very
Sir,
big
first you
man.
need to open the PPT.
Yeah, I have opened.
Yeah, then come to Zoom screen.
Yeah, 1 minute. I'll go back again to that. Yeah, open my presentation. Yeah, I'm coming to my
Yeah,
screen.
Zoom
Yeah.
screen. You will share the green button down there. Share.
Go to share screen. There'll be share screen in your toolbar. Are you able to see share screen?
Yeah, I'm able to see the share screen, but
Then
there's some accessibility issue in my laptop just now. 1 minute.
So you can just open the home screen and there you can have a inbox. There must be.
Yeah, 1 minute.
That way.
Because my presentation is open. 1 minute.
Once you click on the share button, sir,
Yeah, it is.
Arshad, then you will have that white screen and there
Yeah.
you will see your PPT. You click on that PPT, it will be share. Click on that PPT and then there is a
What
share
is
button.
allow Zoom workplace to share your screen. It is not giving me access actually. 1 minute.
You can send the PPT to the.
Yeah, 1 second. I'll just take 1 minute. If I'm not able to, I think we'll take the next lecture first if it is that so. 1 minute. Because it is just showing me a desktop where
I think so. We'll move on with our next
I think,
lecture.
yeah, that will be much better. I'll
Yes.
just much better. I think you move on to the next lecture and then we'll take this lecture.
I hope mine opens up.
Yeah.
Sure, ma'am. Dr. Mitra, you can, I think so, introduce Dr. Awa and we can move on to our lecture.
yeah, 1 second, 1 second. Yeah. So, friends, another emergency of the other kind, the technical kind. Never mind. So, we will go with the last talk in the session on management of endometrial carcinoma. And I have known Dr. Eva Desai, I don't know, for over 2 decades, as somebody really very polite, very knowledgeable, and of course, somebody absolutely appropriate to cover this topic. Madam is a senior consultant in in Zydus Cancer Center, Ahmedabad, and former professor and MCH teacher in Department of Gynecological Oncology, GCRI, Ahmedabad, with over 17 publications in national and international journals, and president of Association of Gynecologic Oncologists of India, with written book chapters and lot of, I know one thing, that there are some people, when you hear them, the impression stays that they are so thorough, so knowledgeable, that it's a pleasure to be, listening there firsthand what's new in the management of endometrial carcinoma. Over to you, Dr. Ava Desai.
Thank you very much for that. I don't think I deserve that, but anyway, I hope my slides open up. Thank you so much, Dr. Saxena, Dr. Saraya. We are always in awe of you. Thank you so much, ICOG, particularly Anjana, and all of you for having me here today. And I'm just going to share my screen. I hope it works. Yes.
Yes, ma'am, it is there, is working. You have to go for full screen.
So is my screen visible?
Yes, ma'am, you go
Yes,
for
okay.
full screen.
So thank you. I'm going to speak on the management of endometrial cancer, and I have only 15 minutes to do it. So I will try to be very brief. It's a very complex issue, not because
Ma'am,
the
you have to go
surgery.
Sorry, ma'am. Can you make it full screen?
It is full screen, ma'am.
No, you'll have to press this button here or this one here.
I did full screen on my.
Okay.
I have done it as a full screen.
Yeah, slideshow बोला मैंने.
मैम
Okay.
आपको दिखाई दे रही है क्या फुल स्क्रीन?
Yes, I can see a full screen.
मैम आपको स्टॉप शेयर करना पड़ेगा और फिर से शेयर करना पड़ेगा, तब आपको एक फुल स्क्रीन वाला विंडो दिखाई देगा ना, उसको आपको
Stop share. Should I do
हाँ.
stop share first?
यस यस
Okay. Now again I share.
हाँ.
Okay.
अब आपको फुल स्क्रीन वाला विंडो दिखाई देगा एक.
Okay.
हाँ, उसको आपको शेयर करना है.
Is it okay now?
Yes, perfect.
Yes, perfect.
Okay. So as I was saying, the surgery for endometrial cancer is not that technically complex, but it's just all the decision making and the individualization nowadays, especially, which we need to understand if we are to properly manage these endometrial cancers. And I'm going to try and simplify that. Okay, now I'm unable to. Okay, so of course, surgery is the cornerstone of treatment. And first of all, we have to go for a total hysterectomy. It can be just a type 1 extrafacial hysterectomy. There is no need in an endometrial cancer for a radical type 3 hysterectomy like we would do for a cervical malignancy. Even if the cervix is involved, we just needed to do a little bit extended so that we get free margins. Then, of course, we need to, it's almost mandatory in all cases to remove the ovaries because there might be occult metastasis, synchronous cancers, subsequent cancers. There may be a tiny occult granulosa cell tumor, which is actually producing the endometrial cancer. And of course, we want to get rid of the estrogen, which might produce an early recurrence. In young women, we can preserve the ovaries if and only if there is less than 50% myometrial invasion and no obvious extrauterine disease and no significant family history. If she doesn't fall in these criteria, then even if she is less than 45, we need to remove the ovaries. Then, of course, come the staging procedures. Why do we need to do these staging procedures? Even if the CT scan or the PET CT is showing no obvious disease in the lymph nodes, why do we need to remove them? Because microscopic disease cannot be seen, cannot be felt, and cannot be seen even on a PET CT. And this microscopic disease, this occult disease, we need to rule out in order to individualize therapy. So the most important thing in staging, of course, is lymph node dissection, and the controversy is to do or not to do and how much to do. I'll try to talk about that. Omentectomy and cytology is not always necessary in all endometrial cancers, but in the high-risk types like the serous and the clear cell cancers, which tend to spread to the peritoneum like ovarian cancers, we must do this. We'll talk a little bit about sentinel node biopsy. And of course, laparoscopy and robotics is the way to go. Most endometrial cancers should be managed now by minimally invasive surgery. And Dr. Limbachia is going to talk about this. So this is the surgical staging of endometrial cancer that we have been following up to the last few years. And we all know this in detail. I don't want to go through it. I just want to stress that if we feel it's an apparent early disease confined to the uterus, and we just remove the uterus and the ovaries, then we would presume it is a 1A or a 1B disease. But in this case, if we do the node dissection and we pick up occult microscopic nodal disease, then this patient becomes upgraded to a stage 3 disease. And then the prognosis changes, the individualization of treatment changes, the adjuvant therapy changes, and we can improve the result because we have staged her properly. And that's the importance of staging. Nowadays, of course, we are following the 2023 FIGO classification, which is very complex, and it also incorporates the molecular markers, which Dr. Harshad is going to talk to us about. For example, a stage 1A in the older classification, if it is a serous type or if it is a P53 mutated high risk, it automatically becomes a 2C. So the FIGO 2023 classification is not just an anatomical staging, but also tells us much more about the risk and what we should be doing for tailoring the adjuvant therapy. So we've seen the benefits of surgical staging are, we know the true extent of the disease, prognosis, individualized planning of therapy, and actually we may actually be able to reduce the number of cases requiring radiation. For example, if we have a 2B patient and we do the node dissection, we prove there is no nodal metastasis, we can actually do away with external radiation and just give her vaginal brachytherapy, just as an example. So there are many benefits. But against this, there are many risks of surgical staging. 20% increase in surgical morbidity. And I think the most important thing about surgical morbidity, to my mind, is the lymphedema, which occurs if you do a proper node dissection in 50% of the patients. This is chronic, it doesn't go away, and it really, really worsens the quality of life in some patients. So that is a big risk of lymphadenectomy. Plus, many of these are older, morbidly obese. They have all these comorbid conditions, and we're doing all these radical periodic node dissections, etc. And we do all this, and then many of these patients will finally turn out to be node negative. So we should try to identify preoperatively a subset of patients who do not require this morbid surgical procedure. And we have to try and do that pre-operatively. So risk stratification is essential to plan not only what surgery to do and how much surgery to do, also for the adjuvant treatment. If we find during our risk stratification that it is a low risk, we can avoid lymphadenectomy altogether. She will not receive adjuvant therapy, and we will avoid overtreatment, surgical morbidity, and toxicities of radiation. If we feel she is high risk for nodal metastasis, although we can't see them on the scans, we will do a thorough nodal staging and then give her individualized therapy. So early stage endometrial cancer, if it is really an early stage, the estimated 5-year survival should be 90 to 95%. But we see, when we feel it's an apparent uterine confined disease, we see that there is a recurrence rate of about 26%, up to 26%. And therefore, we have to find out what are the risk factors in these apparent early stage cancers, which will increase the risk of nodal metastasis and recurrence. And these are the risk factors, the very well-known risk factors. Histological type, endometrioid is good, serous, clear cell, bad, grade 3, high risk, deep myometrial invasion, more than 50%, high risk, lymph vascular space invasion. Focal LVSI is all right, but if it is substantial LVSI, it is a very high risk factor for nodal metastasis and recurrence. Molecular markers, of course, Dr. Parasnas will tell us in detail, but if it is pole mutated, good prognosis, MMR deficient, it was an intermediate kind of a risk, P53 mutated, high risk. Age more than 65, high risk. HER2 we don't always do, but if we get a HER2 positive high risk, but at the same time we have trastuzumab, which is a targeted therapy, which we can use in these patients. So these are the risk factors we need to assess before planning treatment. How do we assess these risk factors? Very simple. When we take our endometrial sample, we know the type, the grade, and the molecular markers now we should be doing preoperatively in our endometrial sample. We do an expert ultrasound, and usually we do a pelvic MRI with contrast, and that will tell us a very, very accurate myometric invasion and also whether the cervix or the index are involved. This will also tell us the size of the tumor. In the Mayo criteria, the Mayo people do feel that size more than 2 centimeters, there is more chance of node metastasis. We will, of course, basically at least do a chest X-ray and a CT scan of the abdomen and pelvis to look for any obvious nodes, especially, or any other disease. PET-CT is not absolutely essential in all cases, although many patients request it and many doctors do always advise it. A CA125 is not really for endometrial cancer, but if it has been sent and it is raised, it indicates extrauterine or nodal disease. So these are the risk factors we need to know in our armamentarium before we plan surgery. And once we know these risk factors, we can decide whether we need to do anything more than a TLH BSO. So we would do no lymphadenectomy if it is a non-aggressive type, an endometrioid type, a low grade, and no or less than half myometric invasion. And about 20% of the cancers would turn out to be like this. So at least in 20% of the cases, we can avoid those morbid surgical procedures. In all the others, we must assess the nodes. So we would do at least a systemic pelvic and common iliac node dissection and excise any enlarged paraaortic nodes. We would go ahead with a systemic paraaortic node dissection, and this is not up to the inferior mesenteric artery, but all the way up to the renal vessels. If there is deep myometric invasion and aggressive histology, like serous or clear cell or P53 mutated, or if we find during our surgery that there are grossly positive pelvic nodes or adnexia. So if we look at this thing, 20% we have avoided the risks of surgery. 80% we are giving them the risks of lymphedema, etc. But of this 80%, finally, only 15 to 80% will actually turn out to have node metastasis. So of the 80%, 15 to 80% will benefit, while the other 60% will not benefit actually from the node dissection and may land up with lymphedema, etc. So we need to strike some kind of a balance. We need to know what's going on in the nodes. We don't want to give them this lymphedema and lymphocytes, etc. And the answer to this, of course, is a sentinel lymph node mapping. It has been established very well now in endometrial cancers, and normally we use the ICG dye, and if we have the Firefly to pick up, we inject usually into the cervix about 4 ml, 2 on each side, and then we start the surgery and we can see the nodes very well. And it is an alternative for evaluation of nodal status and staging. It is found in all the studies so far. It is enough for staging and tailoring adjuvant therapy. It likely does not compromise overall or progression-free survival. The detection rate is very high, sensitivity very high, negative predictive value very high, and false negative rate very low, 2.8%. False negative means that the sentinel node comes negative, but nodes beyond that are positive, and that is very rare. And even in high-risk cases, if all the protocols are followed properly and the SLN algorithm advised by the Mayo Clinic is followed well, there is a very high sensitivity even in high-risk cases. So formerly we used to say how many nodes we've removed. Now we try and say how few nodes can we remove but still manage to know exactly what is going on in the nodes. So sentinel node biopsy planning, a lot of studies are still going on. It's probably the way to go. Adjuvant therapy, we don't have time to discuss in detail. It is very complicated, and tumor board discussion is preferable in many cases. It is, of course, based on our risk stratification, but we need to, lots of times we have to individualize, especially in this era of molecular markers. It can be quite confusing. It can be quite controversial also. We know that radiotherapy consistently and significantly reduces loco-regional relapse, though it doesn't affect the overall survival. Chemotherapy has to be considered in high-risk cases, in some HIR cases, especially if we have a 3C2, for example. And molecular markers are now integrated into the risk stratification and guide the need for not only additional radiotherapy or chemotherapy, but also targeted therapy. For example, if we have an MMR deficient tumor and it is a high stage 3 or a recurrent case, we can add immune checkpoint inhibitors to help in these cases. So these are just examples of how we individualize therapy, adjuvant therapy. If I have a minute or two, ma'am, can I talk about two clinical situations? Just a few slides, is it all right?
I think, ma'am, it would be important, yeah. Please do.
Can I give 2 or 3 slides more?
I think so, yes, ma'am.
Yeah, okay. So we have just before concluding, we have a very common problem of endometrial cancer diagnosed after hysterectomy. And the reasons are a low index of suspicion and no endometrial biopsy taken, even if there is irregular perimenopausal bleeding, etc. And the other reason is that the endometrial biopsy is taken by the conscientious gynecologist, but it shows only atypical hyperplasia. Now, we must remember that up to 40% of the atypical hyperplasias also harbor a concomitant malignancy. So that is the problem. The approach, we very carefully look at the operative notes when the patient comes to us. Were the ovaries removed? They must be removed. Was morcellation done to remove a bulky specimen? And this should never be done even in a bag. We don't have time to discuss this. We review the pathology in great detail, type, grade, LVSI, myometric invasion. We do the molecular markers if none done. And we do a CT or a PET CT scan. And then we discuss in the tumor board how we should follow up this patient or what we should do further. I don't want to go through all these, but the options that we may offer to these unstaged patients are depending on what we find, close observation, restaging surgery with or without radiotherapy and or chemotherapy. So unstaged endometrial cancer, we have to discuss in the tumor board and look at all the risk factors. And the last thing I wanted to talk about is fertility sparing treatment in endometrial cancer. Is it possible? It is possible, but it is highly risky. It is not a gold standard. It is not a standard treatment, and we must discuss in great detail with the couple that they are taking a risk if they want to spare the uterus. And there is this whole list of criteria which must be stringently adhered to. If all these criteria are adhered to or are in the patient, can we do a fertility sparing? And in the fertility sparing treatment, we normally give them a high risk, high dose progesterone, usually Megace 160 to 320 milligram, continuously for 2 or 3 months. We do a hysteroscopy and rebiopsy. If we have achieved regression, then we would continue this treatment. No one knows how long, but at least 6 to 9 months, and then encourage early conception. If at that time there is no response, we would prefer to remove the uterus and do the definitive surgery. But if she insists, then we may increase the dose or change the compound. And the results are, there is about a 50% to 60% response rate, but about 30% to 40% of these do regress and recur within the next 2 years. So even if she does manage to conceive, we should continue some form of progesterone until she goes for definitive therapy, definitive surgery. And it's counseling is very important before we offer fertility sparing to any couple. So I'll just conclude now. Endometrial cancer is best treated by a multidisciplinary team at a specialized center. High risk factors are well established and molecular markers are now integrated into the risk stratification and planning. This is essential to avoid overtreatment, undertreatment, or mistreatment. Surgical staging is an invaluable tool for individualization in high-risk cases, but this potentially morbid procedure may be avoided in a few carefully selected low-risk cases where the risk of nodes is less than 1% and only about 5% would recur. The role of sentinel node biopsy is now well established and should be encouraged for these high-risk surgical patients. Thank you very much.
Thank you, ma'am. That was really exceptionally good. Dr. Abha, would you like to give your comments? Dr. Abha is there? In any case, what I would like to say, ma'am, is that you know what, it was very good that you included that very important entity where endometrial cancer is diagnosed after the uterus has been removed.
Yes.
So the very, very important message for all the practicing OB-GYN is that never not think of endometrial carcinoma, even if it's a perimenopausal patient or it's a menopause. Of course, in postmenopausal patient, we are mostly never missing it. It's the early, perimenopausal patient who goes in for a hysterectomy for a DUB without an endometrial biopsy and then lands up with this. But the good thing about this cancer, it's a kind of friendly cancer. And of course, having listened to your talk very thoroughly, and of course, to follow up with Dr. Harshad's on molecular, evaluation, is going to kind of complement that everybody will have it in their minds that a very important entity, you cannot do more than needed and you cannot do less than needed. And sentinel lymph node biopsy is really very, very important in these cases of hysterectomy. Thank you very much.
Thank you, ma'am. Thank you so much, Dr.
Yeah.
Saxena. Thank you.
Thank you, ma'am. I hope,
Hi.
sir, we can carry on with your Dr. Abha. Would you like to please?
Yes,
I've introduced Dr. Harshad, but you can introduce the topic.
I would like to thank Dr. Abha Desai for a wonderful talk on management of endometrial cancer. It was so lucid and so well explained in such a simple way. I think it must be a great learning for the postgraduate students. Thank you, Dr. Abha Desai, for your wonderful talk on management of endometrial cancer. Thank you.
Thank you much. Thank you so much, doctors.
So now we will have Dr. Harshad. Sir, please share your screen. And
Can you see my screen now?
Yes, we can see. Make it full screen.
Yeah, it's fine now. And am I audible?
Yeah, you are audible. Make
sir,
it full
but
screen.
Yeah, thank you. First and foremost, let me thank the chairperson for those kind words. And also let me thank Foxy ICOG, especially Sarita and Anjana for inviting me today to speak on this very complex actually topic. This is, I think genetics is something which is very complex, and most of the times it is very difficult to understand. But even then, the beauty of this molecular basis is that it has been incorporated in our day-to-day practice now. What once upon a time was thought that genetics could not and clinical practice could not go in hand, but today this is one subject where we actually incorporate all the basis of molecular basis into our practice. Just to introduce endometrial cancer, we all know 6 commonest cancer in the globally. Now, what is the necessity to actually go ahead and have a molecular basis for endometrial cancer? As you all know, more than 75%.
Sir, can you make it full screen?
I am full screen.
No, sir, we can't see.
Okay, one sec. Okay. Now?
Make it slideshow.
No, sir.
One minute. Now?
Not yet.
Yeah, one second. I think today it is decided that
सर आप स्टॉप शेयर करिए और उसके बाद फिर से शेयर करेंगे ना तो आपको स्लाइड शो वाली विंडो दिखेगी, उसको आपको शेयर करना है.
हाँ, स्टॉप शेयर करता हूँ या
अभी आप शेयर करिए, आपको देखो स्लाइड शो वाली विंडो दिखेगी.
हाँ.
नहीं सर, स्टिल इट्स नॉट इन फुल स्क्रीन.
Okay, now is it full screen?
No.
No, sir, not yet. सर ऊपर ऑप्शन है डिजाइन के बाजू में एनिमेशन एंड स्लाइड शो, आप स्लाइड शो में जाके फिर एक बार ट्राई कर सकते हैं।
Actually, is it now not full screen now?
नो सर,
Not yet.
नॉट येट।
I think I'm doing something wrong with me.
I think so. You continue, sir, because the time is going on.
Yeah, is it seen now?
Yeah, it is seen, but is not seen in the full screen.
Okay, fine.
You continue with your talk.
Yeah, so as we all know, that 75% of all the early stage disease, most of the disease is at early stage, but even and they have very favorable outcomes. But we realize that a lot of patients who would actually recur come at higher stages, and the response to the conventional chemotherapy is low, and clinical outcomes are extremely poor in these patients. So that is when that was the need for going ahead with a molecular basis of the endometrial cancer. Till now the conventional pathological classification has been type 1 and type 2. Type 1, all of us know, is a low grade endometrioid carcinoma with which occurs in a obese patient with a high BMI, usually not very aggressive. As against that, type 2 is which occurs in postmenopausal
Slides are
women.
not moving. Slides are not moving.
No, I have not yet moved the slide.
Okay, fine. Sorry.
Yeah.
Okay.
Yeah. Which is much. Can you see the dualistic classification? Is that seen there or no?
No. I think so. You share your slides with somebody. Keep in the group. We will do it from here.
Okay.
WhatsApp me the slides. Yeah, now it is seen.
It is seen?
Yes.
Yeah. So this is the type 2 is where it is postmenopausal, much aggressive, high grade tumors, and a lot of times there are going to be recurrences, but this occurs in only less than 20% of the patients. Is the slide seen?
Yes.
Yeah. Okay. So the clinical implication of this pathological classification is the problems that we face is that this clinical classification is subjective. The subtypes, the grade assignment differs, especially the high grade tumors. And because you assign the different grade to the same tumor, so treatments are going to be different, and therefore the outcomes are going to be different. So we are unable to accurately predict the risk of recurrence and the choice of adjuvant therapy. And that is when we realize that when you are doing managing patients, there is either over treatment or under treatment. So there was a need for a more reproducible, objective, biologically informative system to classify these tumors and enable risk classification, and that is the TCGA classification. It is now the TCGA classification basically uses the genomic information and the somatic copy number alterations and the tumor mutation burdens to classify these tumors into 4 types. The first is the POL-E, which is ultra mutated. Second is the microsatellite instability, which is hypermutilated. Then the copy number low, which is endometrioid, and the fourth is a copy number high, which is serous type. Just before going on to the subtype, I'm just going to go into the normal replication and DNA repair. So as you can see here, the two most important points areas. One is when the DNA actually splits and tries to replicate. There are two areas. The first area is the pole E, that is the exon nucleus domain. Now this is responsible for proofreading. So if you realize if there is a problem in the proofreading, then again there is going to be the copies that are going to come out are going to be defective. And second area in which there is going to be a problem is the can be a problem is a mismatch repair complex. Now in nature, when the DNA replicates, this mismatch repair complex proteins actually see to it that the if there is any mismatch, they correct it. In case there is a problem in this area also, you are going to have a mismatch repair complex problem, that is the MMRD, that is mismatch repair protein deficiency. So I think these two areas is what everybody should understand. So let's come to the first type, and the first type is actually, as you can see here, is the pole ultra mutated, which is the in which you have the exon domain is responsible, which is actually defective, and therefore you get a ultra mutated picture. Now here, what do I mean by ultra mutation? Here, that means there is the high somatic mutation frequency, which is more than 100 mutations per megabase. And here, as I can show you in the last the slide here, there are three different types of endometrial cancers that are seen histologically. But mind you, though one of them is endometrial cancer grade 1, other is grade 3, and other third one is the serous type, all three of them are basically a pole mutated endometrial cancer. So all of these three are going to have good prognosis. So this is this is where we would have either over-treated or under-treated. But now, because when you know that this is a pole E mutation, then your treatment is going to be curtailed, and you know that the prognosis is going to be good. Similarly, you have a microsatellite instability, the MSI hypermutilated. Now, in this group, the one which I was talking of, this MMR, that is the mismatch repair protein dysfunction. Now, there are 4 proteins here: MLH1, PMS2, MSH2, and MSH6. Now, these, if there is a defect in this, you are going to have a high mutation frequency, which is between 10 to 100 mutations per MB. But most of the time, these tumors are just mostly endometrioid tumors. And what can you see here when you have this replication problems? As you can see in this slide, the arrangement of the nucleotides has changed because of the change in the MMRD, which is deficient. So this mismatching continues, and that is why you get an abnormal nucleotides. Now, the third type is the copy number low. Now, when we have a somatic copy number alteration, what do I mean by that? Means you have an area, as you can see here in the blue. This is an area which usually gets duplicated. Now, after duplication, if you see, there are two of them, two of the areas which have so the copy number is going to increase. Now, how much is that copy number increase? Based on that, we can actually predict that whether these are what type of tumor it is and what is the prognosis of this tumor. Most of these copy number low tumors are low estrogen progesterone positive. If you have a high copy number, that means a high copy number, high somatic copy number alteration is high. These are usually high grade serous ovarian cancers, similar to them. Now, here you have the main problem is a P53 gene, which is a problem. Now, what is a P53 gene? Now, P53 gene is a tumor suppressive gene which regulates the cell division and cell death, and is located in chromosome 17. Now, these are very high grade tumors, mostly serous, and these are the most problematic as far as treatment goes. Just to give you an idea of what the P53 protein does, as you can see here, it is responsible for actually removing those cells which are abnormal there and causing apoptosis, so that those abnormal cells are removed from the system. But when that is the problem here, that is when you get malignancy. So based on these 4 types, this is the 4 types which you can see: pole E, MSI, hypermutated, copy low endometrioid, and copy number high serous types. Now, this is theoretically up till now, this was all okay for all of us. So how do you now implement this TGCA classification into practice? Because we will not have in the clinical practice whole genome sequencing available for us. So in order to solve this, or how clinicians will identify the patient subgroup, a group from Vancouver came forward with a proactive molecular risk classifier for endometrial cancer, which was called as PROMISE. And they brought in the idea that we must do 3 IHC stains, that is P53 and MMR proteins, then poll exonucleus domain hotspot sequencing as surrogate markers for TGCA molecular subtypes. Now, by Sanger sequencing, this can be done. Now, if you are able to do this, you will be able to get these 3 subtypes. So let's see what we do with IHC. If you do the first and foremost, IHC is very simple. It is available in most of the labs because it is now an established modality for colonic cancers. So if you have this mismatch repair protein deficiency, then it will be termed as microsatellite instability, and that is where you identify them in the MMR deficient category. Then you can also do P53 IHC. If you do P53 IHC, this is going to tell you, now this is very common, all of the labs are doing it. So if you do P53, and it is also not very expensive, so you can come to know which is the worst prognosis subtype, which is the high copy type. So you can identify this just by doing this simple test. So this is the second test that you do. Now, after you get a sample, and if you do the IHC and you find out your MMRD is ruled out and your abnormal P53 is ruled out, then the rest of them can be pole E. Now, you can also do a PCR based amplification, or you can do the next generation sequencing. Now, if these are available, you can surely diagnose even the last type, that is the pole E variant. Now, how do I integrate the molecular classification into my clinical practice is what we discussed. Now, what impact does this molecular classification have on treatment? So the impact is one, on the progression-free survival, preoperative setting, adjuvant treatment, surveillance, and recurrent disease. So progression-free survival, as you can see here, that means what is the prognosis? The pole, now this figure is very important, slide is very important. Pole E has the best prognosis of all, number one, and the copy number high has the worst prognosis. So these are two things that the student should remember. Rest of them fall in the intermediate zones. So if you have a pole ultramutated tumor, the prognosis is good, and if you have a high tumor copy type, the prognosis is poor. Now, as far as hypermutated tumors are concerned, you have intermediate prognosis for that, and low tumors also, the low copy type also you have intermediate prognosis. Now, what is the impact on the preoperative setting? Just now, the previous speaker, Dr. Desai, was just talking about how you can actually incorporate it. Is that if you have a high-grade endometrial cancer, normally what you would have done would have given her adjuvant chemotherapy, but here adjuvant therapy, not chemotherapy, maybe radiation. So here, when you know that she's a pole E mutation, then you can just do a simple hysterectomy and bilateral salpingo-oophorectomy, and that may suffice in a very early stage disease. Whereas if you have a P53 disease, it is a very aggressive disease. You need to do lymph node dissection. You need to treat her as if it's like a ovarian type of cancer, and so you have to also go ahead and do omentectomy along with it. So these changes can be done. Now the impact on adjuvant treatment. Adjuvant treatment can be individualized based on the molecular subtypes, and for here the 4A trial is actually been very helpful to us. So if you have just the pole E type, surgery alone can suffice. And if you can see, if you have a P53 which is positive and it is a high serous type of disease, then you have to give adjuvant chemotherapy to it. And the hypermutated and the low copy type, you can actually have to evaluate to give whether you can give adjuvant radiotherapy or add chemotherapy along with this or not. I'll not go into the trial. As far as surveillance is concerned, if you have a P53 aberrant endometrial cancer, then yes, you must be more vigilant on this, and surveillance has to be much more than a normal pole E mutant tumor. As far as recurrence tumor is concerned, now it is found that you can use checkpoint inhibitors. Now that was what madam was saying before me, that you can use pembrolizumab is the one which actually is now of FDA approved for a rapid response in pre-treated or a mutated cancer which is either progressive or has got recurrence. So in a nutshell, POLE, if you have a POLE tumor, as you can see here, more than 100 mutations, MMRD 100 to 10. So this chart actually tells us that we can subdivide these tumors into 4 clear-cut categories, and they have totally different type of managements that can be offered to them, and therefore we'll be able to individualize the treatment in a much better way. Now there are no one-size-fits-all solutions, and so ISGO and ISRO have put in recommendations which are now actually incorporated into the FIGO staging. I'm not going to discuss FIGO staging because this is beyond the purview of today's discussion, but you can incorporate this into the FIGO staging for treatment and have a good outcome. And now, so that's what we are looking at possibly. Initially, historically, we were used to have type 1 and type 2 diseases, chemotherapy, hormone therapy, radiation. Currently, now we are talking of the TCGA molecular subtypes, immunotherapy. And now the days have not gone far when we are going to have personalized treatment, combination treatments of immunotherapy, chemotherapy, targeted therapies, and radiation, so that the treatment is very pinpoint, and there are no side effects or to the patients, and no morbidity and mortality in this process. So to summarize, this genomic classification is very important for a better understanding of the biology of the endometrial cancer. That is, it gives us a differentiated risk evaluation, improves the estimation of prognosis and therapy response. It de-escalates the adjuvant therapies for patients who do not benefit from them. At the same time, it escalates the adjuvant measures for patients with aggressive disease, especially the P53 type. And it provides guidance in the future for individualized treatment, like fertility sparing treatment, like what madam was saying. If you have a patient where you need a fertility sparing therapy surgery, and if you have a high aggressive tumor, you better be careful that whether to offer this patient or not. Thank you very much for a patient hearing.
Thank you, Dr. Harshad, for your very informative talk on molecular basis of endometrial cancers. I think you have so well explained which are the low risk ones, which are the high risk ones, which are the intermediate risk ones. And apart from that, how to individualize your treatment, like how to decide, because we all know that if we do over treatment, we are increasing the morbidity, and that is very important. So when to add adjuvant therapy, when to add chemotherapy, when to add radiotherapy, I think all these immunohistochemistry study, they can help us to choose the modality of treatment. I think this is a very good advance, and I think most of the cancer centers, they are already doing it, but I think this is a very good way. And the way you have explained, you have made everything so simple that even a person who is not doing gynecology, that person could also understand each and every point, like how to decide the treatment, how to select the treatment, how to add any adjuvant therapy, what will be the survival, what will be the prognosis. So excellent lecture, Dr. Harshit. I really appreciate it. Thank you so much.
Thank you. Thank you so much. One thing which I would really like to add to this, Dr. Abha, Dr. Archit, and all our esteemed seniors, that the message is loud and clear. A practicing gynecologist must evaluate properly, which Dr. Sarita will be elaborating, and then understand the disease and so refer them timely. Unfortunately, our clinicians at the periphery, they are very happy with prescribing a PET scan, and they do not know the basis of prognosticating, and they will be giving inappropriate and wrong prognostic factors. So that is very important for us. At least we should have a minimum understanding, which our two speakers have done beautifully. Thank you very much, sir.
Yeah.
Thank you.
Thank you, chairpersons, and thank you, speakers. Dr. Sarita is still delayed. So I think from here we move on to session 2. She will still take time. So we are moving on to session 2. I hand over the mic.
Before we leave, Dr. Varsha, I would just like to thank the organizers, especially Dr. Sarita, and all of you for inviting us to be chairpersons of this very important session. My regards to Usha ma'am, and thank you so much.
Yeah, thank you, Dr. Abharani, and thank you, Dr. Mitra. So now I hand over the mic to Dr. Sapna, who is my co-MOC for today. Sapna, I take over.
I will close my slide, but I will be listening.
Yes.
Thank you. The session is
Thank
too
you,
good.
ma'am. A very good evening to one and all. Now moving to the session 2, I invite the chairpersons for the same. First of all, can I have the slide? So it's my pleasure to invite Dr. Meena Sawant Madam. She is a senior consultant, head of department obstetrics and gynecology, Kurji, Holy Family Hospital, Patna. She is the president of Patna Obstetric Gynec Society, a governing council member of ICOG. She was fastly associated with Foxy.
Thank you, Dr. Sapna. I think that's enough. We'd like to hear
Yes,
about
ma'am. Welcome, ma'am. And now I invite Dr. Alka Pandey, ma'am, a professor and head of department, OBGY, Lord Buddha Koshi Medical College, Saharsa. And madam needs no introduction. She was our past vice president, past ICOG governing council member. And she was the president of Patna Obstetric Gynec Society. And she was awarded the best gynecologist of Bihar in 2021. Welcome, ma'am, for the session 2.
So good evening, everyone. Thank you, organizers, for the opportunity given to me and us, both of us. And it's a marvelous session that's going on. It's my pleasure to introduce Dr. Deepak Limbachia, who we know is a remarkable ultrasound laparoscopic surgeon. He did his MBBS from Ahmedabad, MD from again BJMC Ahmedabad. His expertise in laparoscopic radical hysterectomy and carcinoma of cervix, management of bowel endometriosis and fertility preserving endometriosis, laparoscopic metrectomy in carcinoma cervix, laparoscopic para-aortic lymphadenectomy in gynecology. Sir, we know is an expert. Sir, over to you. Dr. Deep, he's here? Doctor, yes.
Hi. Dr. Deepak is here.
दीपक भाई તમે म्यूट पर છો आप म्यूट है दीपक भाई आप अनम्यूट कर
उनका अकाउंट कौन से नाम से मैम?
Deepak Limbachia, he is there.
उसके नाम से है आई थिंक अंजना बेन આપણે એને અનમ્यूट કરવા પડશે અનમ્यूट नहीं થતા
पूरी DIPS के फाइंड कर DIPA के
केले को
यस यस उन्हीं को करिए ना
Sir, we have made you co-host, please.
Okay.
Okay, Dr. Deepak, now you are unmuted.
For wonderful session, Anju madam, કેમ છો?
Yes, fine.
Okay, I'm going to share my screen, and my topic is today laparoscopic management of the carcinoma of the endometrium.
1 minute. 1 minute. Sorry to interrupt. There is going to be a party at the end of the webinar. Happy birthday, Dr. Deepak.
Yes.
Happy birthday, sir.
Happy birthday, sir.
Thank you. Guru. Okay, madam.
Yes, you are fine. You are full screen. You can continue.
Now, coming to the introduction, already it is done that endometrial malignancy is the fourth most common malignancy in a way. However, its incidence in India is increase in 2022 17,420 cases with 6,845 deaths in India is reported. Prognosis of this depends upon the stage of the endometrioid variety. Comprehensive surgical staging for the C endometrium, that is a hysterectomy, bilateral salpingo-oophorectomy, pelvic and para-aortic lymphadenectomy depend upon the requirement, omental biopsy, and the peritoneal washing. Now, question pops up for why we need to do comprehensive surgical staging. With the help of the surgical staging, we can identify the high risk factor that can sometimes there is a upstaging of the apparently early stage disease. So this can help us in tailoring the post-operative adjuvant treatment. Thus, it may affect the prognosis of the patient. The overall 5-year survival rate with the patient who are treated with the clinical stage 1 disease is a 51%, and the patient treated with this comprehensive surgical staging, that is a 88%. So I'm not going to further emphasize the significance of the comprehensive surgical staging. Now, root of the comprehensive surgical staging, laparoscopy should be embraced as a standard surgical approach for the comprehensive surgical staging for the endometrial malignancy. Now, I'm going to share a case with the video. She was 52 years old, para 2. She had a PMB, and MRI arranged, and it showed that 4 by 3 centimeter growth in endometrium, invading the myometrium. Biopsy confirmed moderately differentiated endometrial adenocarcinoma involving the cervical stroma on a ECC. Now, this is a video that here we can see the uterus. We are not manipulating the uterus. We are doing the packing of the vagina. And see here, first we separate the bladder of the cervix and the vagina. And the opening of the 6 avascular spaces, first is separation of the bladder and both sides, pararectal and the paravesical space, and posteriorly rectovaginal space. By that way, we can how to make easy this surgery. Now, the paravesical space, that is approach from the central to the lateral, and the floor is levator made by the levator NI here. This is a left side levator NI. Now this is anteriorly, we can see 3 spaces, both side of paravesical space and centrally uterocervicovesical. And laterally here we can see the ureter. Now between the ureter and the interiliac artery is the gate to the pararectal space. And here we can see the inferior hypogastric nerve that we identified and lateralize it, and we work medial to it and try to lateralize this nerve as much as possible to do the nerve sparing surgery. Now the mirror dissection is carried out on the left side. Once we see the lateral border of the ureter, we need to work on it until we get the uterine artery. Now between the ureter and the interiliac arteries again get to the pararectal space, and here we need to identify this inferior hypogastric nerve. This is a 2 space, medial and the lateral pararectal space. Now here, the separation of the rectum of the posterior vagina, we need to work into this proper plane. The carbon dioxide is helping us like a blessing, and it is moved away from our operating field, so we can have an adequate oncological margin. Now, the most important step is the separation of the ureter from the ureteric tunnel, deroofing of the ureter. We are keeping the uterine artery intact till we complete this space dissection and the ureteric tunnel dissection. And here we can appreciate the knee joint of the ureter. Once we see that, we work inferior surface of this tunnel and the ureter is freed of this area, and the ventral parametrium is moved toward the specimen. For the left side, the same steps, working on a medial wall of the ureter. Vesico-uterine ligament is identified, which carries cervicovesical artery and the vein. The left hand grasper is safeguarding the ureter, and here you can see the working on the ventral parametrium, and that is moved on a specimen side. So here you can appreciate the beautiful relation between the intact uterine artery and ureter. Now, IPL is taken care. In this case, there is no need of taking up too much parametrium and the paracolpus. Both sides of the parametrium paracolpus is done. Now, this is an application of the endo-GI stapler to prevent the tumor spillage. And this is enclosed colpotomy. Here it is done. Now the distal margin is taken away with the ligature. This is a R&D publication from our center, first of the India, vaginal closure before colpotomy, endostapler to prevent tumor spillage. Now coming to the lymphadenectomy, the indications of the lymphadenectomy: high, intermediate, and high risk disease, high histological grade, grade 3 endometrioid variety, deep myometrial invasion means more than half thickness, cervical involvement is there, LVSI positive, and non-endometrioid histology like a serous carcinoma, clear cell carcinoma, or carcinosarcoma. Now for the lymphadenectomy, here we need to proceed for the systematic lymphadenectomy, which includes pelvic and the para-aortic lymphadenectomy. Now this is inferior mesenteric artery. We can see this is bifurcation of the aorta. This is the left side of the common iliac artery. This is the right side of the common iliac artery, right side of the ureter. Below to it is a psoas muscle here. And here, this is a impression of the inferior vena cava. We can see with the bluish discoloration. Now lifting this fibrofatty tissue over the inferior vena cava here. That is a common iliac nodes. This is for the right side. So with the tip of the ultrasonic energy, go through the perinodal tissues and you can pull it out, all this fibrofatty tissue along with the lymph nodes. Now this is a presacral nodes. This is a bifurcation of the aorta into the right and the left common iliac artery. And below to it is a left common iliac vein that is going to meet right common iliac vein to become inferior vena cava. These are the flat lymph nodes over this vein. So do not give too much traction, because deflating of this vein gives a counter traction. And ultrasonic energy divides very fast. So we need to be careful, do not give too much traction. So this presacral and the left common iliac node, now it is merging with the right side external iliac nodes. Below and lateral to the external iliac artery, we can see the impression of the external iliac vein. Working on a lateral wall, still going lateral, there we can see the obturator now as well. So the taking all this fibrofatty tissue from the lateral side will be helpful when we are working on a medial side, because the blood supply would be cut. And this is a proximal part of the obturator now. So the idea is to work 360 degree to the vessels and the nerve, so that all the fibrofatty tissues can be removed. Now this is at the bifurcation. Now we can see the medial wall of the external iliac vein, and below to it is we can see the internal iliac vein. Now medial inferior to the external iliac vein. Now we are approaching for the Rosenmuller space to get the Rosenmuller nodes, and this is usually enlarged. The small nodes here we can see that was hidden just on lateral wall of the extrailiac vein. Now it is separated. This is the arcuate ridge of the ilium. You can see the obturator now and the obturator internus muscle. So I'm trying to remove all this fibrofatty tissue, almost radical way, and this would be the final view after stripping it from the interiliac artery and obliterated umbilical artery. So this is a, and now coming to the omental biopsy, that we need to do complete omentectomy in a high-risk histology. And in this thing, optimum size would be 5 by 5 centimeter. And any abnormal area on an inspection must be removed and send it for the biopsy. Now the indications of the para-aortic lymphadenectomy we already discussed. So in this, we start from the common iliac artery, right-sided, safeguarding the margins both sides with the ureter, both side of the ureter. This is the right side of the ureter, working on a right side of the patient. Here, this is left side of the ureter, left side of the psoas muscle, left lateral para-aortic nodes, lateral cutaneous nerve we can see in this patient. This is inferior mesenteric artery. Now, this is again working on the lateral wall of the left lateral to the aorta. Now here, this is centrally we are going, and left gonadal vein we can see, and that drain into the left renal vein. Now this is aortocaval nodes. Here you can see the depleting of this IVC. So at the time of the giving the traction, we need to be a little bit careful. This is the right gonadal artery is clipped. This is left renal vein here. And some of the lymphatic channels here, it's better to clip to avoid the lymphoria or the lymphocele. So this is a final endo view after doing the para-aortic lymphadenectomy. This is a left renal vein, this side of the psoas muscle, lateral cutaneous nerve, ureter on this side. Thank you very much.
Thank you, Dr. Limbachia. That was fantastic. We know what a magician you are with your laparoscope, and what basically we know that any surgery, except of course cesarean, is possible with this. And so it's beautifully shown, especially his speciality, the parametrectomy, and where we need to do. That was wonderful. Thank you so much.
Thank you so much. Thank you so much.
We can go to the next topic. You, please share the CV of Dr. Dilip.
Dr. Abha is, Dr. Alka Pandey is here? I don't see her.
Anyone
So,
can.
yeah. So, welcome Dr. Dilip Srinivasan. He is practicing medical oncology in Ahmedabad from 2002. And sir, over to you.
I'll be sharing his slide, please.
Yeah, please
Stop
do
the
that.
slide.
Yeah, it is not fair to a speaker. Okay, his detailed CV also, if possible.
No, he doesn't want to share his details.
Okay, okay.
Okay. Slides are seen? Dr. Dilip?
Yes, yes, we can see.
Dr. Dilip, I think so he has to unmute himself.
Yeah. Hello.
Hello?
Can you hear me, please?
Yes, we can hear you, sir. You tell me when to go to the next slide.
Yes, ma'am. I will do that.
Hmm.
So, thank you so much, everybody. I'm ex-SRMC in Chennai. I was an assistant professor there. Then I came to Ahmedabad, did my DM in medical oncology and critical care. It is a pleasure. Thank you so much, Chairperson. Thank you so much, Anjana Ben. After fantastic talks by Dr. Ava Ben, Dr. Deepak Limbacha, and Dr. Parasnas, I'll do the honors of taking the bench to the bedside. So can you change the slide, please? So we look at CA endometrium. You have various types, as has already been talked about. So nothing much that I have to. It's just a slide with which will make you familiar with all the types. Endometrioid, serous, and clear cell are the most common types. The rest are also seen, but are seen in very less numbers. Can I have the next slide, please? So stage 1 is restricted to the corpus uteri with less than half myometrial invasion. 1B is equal to more than one half of the myometrial. I'm reiterating all this because it will have effect in the further discussion that we have. Stage 2 is invading the cervical stroma but does not extend beyond the uterus. And 3 is local or regional spread of the tumor, which in A would be invading the serosa of the corpus and or the adnexate. B would be vaginal and parametrial involvement. C would be metastasis to the pelvic and the paraortic lymph nodes, with positive pelvic nodes being C1, paraortic nodes being C2. Bladder or bowel mucosa involvement would be 4A and distant metastasis being 4B. Can we have the next slide, please, ma'am? So treatment recommendations. This is FIGO 2009, but I have not deliberately not taken into account the latest one right now because I thought I'll keep it simple at first and then introduce you to the more complex characteristics. Stage 1A, grade 1 or grade 2 is surgery followed by observation. Grade 3 is surgery followed by observation or intensity modulated radiation. 1B, grade 1 or grade 2 is intravaginal RT. Grade 3 would be IMRT. Less than 50% invasion, grade 1, grade 2, either intravaginal RT or IMRT. The choice is up to the radiation oncologist. Grade 3 would be IMRT versus IVRT plus chemotherapy. With more than 50% invasion, grade 1 and 2 would be IMRT. Grade 3 would be IVRT plus chemotherapy. Stage 3 would be radiation plus paclitaxel plus carboplatin into 6 cycles. By and large, early stage endometrioid carcinoma does not require chemotherapy, but serous etiology does. Serous is serious. Next slide, please. So we come to the treatment of stage 3. Stage 3, there were studies done, what is known Mango Iliad and Portec 3. The EBRT, that is external beam radiation with chemo radiation, was compared. The Mango Iliad 3 did not show any advantage of one over the other. The Portec 3 showed a mild improvement with chemo radiation, not going to very great significance. Whereas chemo radiation was compared to chemotherapy alone in the GOG 258 trial. And it was found to have no significant difference in the OS. OS is overall survival, but a mild reduction in local recurrence with chemo radiation and a mild reduction in distant metastasis with chemotherapy alone. So there is nothing much to choose between them. Can I have the next slide, please? So there were 3 factors which were independent predictors of relapse and death from endometrial cancer. One was more than 50% myometrial invasion. Second is positive peritoneal cytology, including the washings. Third is aggressive histology, which can be defined as grade 3 endometrioids or any serous clear cell or undifferentiated tumor. The 5-year relapse rates were 13% for patients with no risk factors, 27 for patients with one risk factor. Sorry?
Unmute now. Who
I
is
think
talking?
somebody's the 5-year is the 5-year relapse rates were 13% for patients with no risk factors, 27% for patients with one risk factor, and 62% for patients with 2 or more risk factors. The corresponding 5-year rates of death were 11, 20, and 56% respectively. For patients with stage 3 disease, 2 or more risk factors, especially positive peritoneal cytology, and you require to give full systemic chemotherapy, that is 6 cycles of paclitaxel and carboplatin. This is definitely preferred over chemoradiation. For those with only one risk factor, say lymph node involvement only, using chemoradiation is adequate. So the patient population is very diverse. So for most patients, when we come to it, 4 cycles of concurrent chemoradiation followed by 4 cycles of paclitaxel plus carboplatin, which is also known as TC, will serve best. If peritoneal cytology is positive or there is a high risk of peritoneal involvement, then 6 cycles of paclitaxel plus carboplatin should be considered. If molecular profiling is done, as has been very wonderfully done, described by Dr. Parasnis, and it has been found positive, then immunotherapy and targeted therapy can also be used. Can I have the next slide, please? So now we come to stage 4. That is our domain. The poor medical oncologist starts handling here. This is best handled with chemotherapy, immunotherapy, and hormonal therapy. Madam Ava Ben has already talked a bit on hormonal therapy. I'll restrict myself to chemotherapy and immunotherapy. The first line chemotherapy was started initially historically with paclitaxel plus doxorubicin plus cisplatin. I remember this from my GCRA days, from the times I started my career as a medical oncologist. This was then compared later with paclitaxel plus carboplatin, which is known as TC, taxane carboplatin. This was found to be non-inferior, less toxic, and hence it has gained more popularity. For those who have taxane allergy, neuropathy, or don't want too much of hair loss, can go with liposomal doxorubicin plus carboplatin. But the gold standard as of now is still paclitaxel plus carboplatin, 4 cycles or 6 cycles, depending on the nature of the disease. Can I have the next slide, please? So second line. First and foremost, a disclaimer, response to second line chemotherapy is poor. So if less than, if the recurrence occurs within 12 months of using paclitaxel plus carboplatin, then use other agents such as gemcitabine, oxaliplatin, ixabepilone, docetaxel, pegylated liposomal doxorubicin. Do not use plain liposomal doxorubicin. You have to always use pegylated liposomal doxorubicin in this. If more than 12 months after use of TC, then you can again retry taxane plus platinum, probably changing the paclitaxel to docetaxel and the carboplatin to cisplatin. Can I have the next slide, please? So testing for, as Dr. Parasnis has said, IHC, PDL1 and NGS, next generation sequencing, should be done for all cases beyond stage 1. Microsatellite instability in hypermutated cases as well as mismatch repair deficient DMMR cases are suitable for immunotherapy and target therapy. So pembrolizumab and dostarlimab are available for these, and they are quite effective with response rates of 57 and 49% respectively. I wish to clarify that response rate is not overall survival rate. Response rate merely means 20% reduction in the tumor size, which might ultimately convert into a better overall survival rate. And you have avelumab and durvalumab with response rates of 27 and 43% respectively. So another drug which has been commonly used now is lenvatinib, which is a multi-targeted tyrosine kinase inhibitor and has gained a lot of prominence in the treatment of advanced endometrial carcinoma. Standalone, the response rate was 14.5%, but in the Keynote 774 trial, it was tried in combination with pembrolizumab, and that resulted in about 38% response rates with a median overall survival of 17.4 months. The other drugs which are being used are cabozantinib with nivolumab, as well as lucitinib plus nivolumab. I'm doing a lot of name dropping, but I think you can look it up later for the students. Can I have the next slide, please? These days, HER2 and its monoclonal antibodies have gained favor in a lot of things other than breast cancer, including GI cancers, and so on and so forth in endometrial cancers as well. So this is positive in 20 to 30% of serous cancers and in some high-grade endometrioid cancers. See, per se, serous cancers are very notorious for recurrences and for poor response to treatment. So if it is positive in 20 to 30%, addition of trastuzumab upfront to paclitaxel plus carboplatin has very good efficacy. In addition to this, pertuzumab also has been added, and this has also been found to be quite useful. Can I have the next slide, please? The TP53 mutations are being tried to be addressed with adavosertib, but not much of success has been seen. Bevacizumab in combination with paclitaxel and carboplatin has been found to be quite effective in PTEN mutations and are countered with has been found to be quite effective. PTEN mutations, are countered with mTOR inhibitor combinations like temsirolimus, everolimus, ridaforolimus, but these are very toxic with lot of complications, including this thing, vesicovaginal fistulas and other problems. Can I have the next one, please? So the anti-angiogenic agents which can be used are aflibercept, bevacizumab, cedarinib, sorafenib, sunitinib, nintedanib, cabozantinib, brivanib. Bevacizumab, sorafenib, sunitinib, cabozantinib and are the ones I have the most experience with personally, and they're quite effective. Can I have the next slide, please? And with that, we come to the end of the lecture. I think the 3 minutes extra, I am willing to take any questions.
Thank you, sir. That was a very lucid, simplified lecture of a very complex complexities that we have in treatment, but you made it sound very simple and very clear. Thank you for such a lucid presentation.
Thank you very much, ma'am. It's my pleasure.
Yeah. Sapna, we can move on to session 3.
Yes, ma'am. Yes.
Yeah.
Thank you very much, sir. After the excellent talks on endometrial CA, now moving on to session 3, the lesions on vulval and vulval cancer. So I would like to invite the chairpersons, Dr. Anita Sabarwal ma'am, Foxy Champion, Wonder Foxian, Foxy Superstar. She is a recipient of Foxy Dhira Award, International Foxy Achiever Award, and she is the president of Forum of Obstetricians and Gynecologists of South Delhi, a North Zone coordinator of Public Awareness Committee. And she has been a master trainer of Dhira by Foxy, certified UNICEF GBV trainer, and ex-medical consultant for Vanita magazine and Amar Ujala newspaper. I welcome you, ma'am, to chair the session. So I invite our second chairperson, Dr. Nishi Chaudhary, ma'am, assistant professor at VMMC and Safdarjung Hospital, New Delhi. Madam is a trained colposist certified by ISCCP. She has worked as a research officer in Stillbirth Registry, a project funded by WHO, life member of Foxy and many organizations, editor of AODGD, and has several publications to her credit. So I welcome you, ma'am, to chair the next session.
Thank you. Thank you so much, Dr. Chauhan and the entire team for giving me the opportunity to be part of this prestigious webinar. It's truly a big learning experience. And I'm really lucky because I've come to Ahmedabad only for the Fertivision. So I'm coming in between. And it's great to introduce Dr. Dave, I think, who's one of the jewels in the field of gynae-oncology, who will be speaking on management of vulval cancers. So I invite him to start with this presentation. Dave, sir. If I could see his PPT, I couldn't see the CV. Yeah.
Parisima Dave, ma'am.
Ma'am,
is
sorry.
yeah.
Sorry. Yeah.
Ma'am is Professor
Parisima
yeah.
Dave, ma'am.
Yes.
Yeah.
Am I
So
audible?
I would like to tell more about her. She's a Professor Emeritus, Gujarat Cancer and Research Institute, Ahmedabad, and former Professor and Head of Gynae-Oncology, former Deputy Director and MCA teacher also at GCRI, Ahmedabad. A very well-decorated person. So I'm really very, very privileged that I could introduce ma'am. So ma'am, please go on with your presentation.
Thank you very much.
Eager to hear.
Am I audible?
Yes,
Yes, ma'am. Yes.
Thank you very much, ICOG and Foxy, and especially Dr. Anjana Chauhan for collaborating all these things. Can you see my slides also? I've already shared.
Yes, ma'am.
Okay.
Yeah, so we can see. We can see.
And it's full screen, right?
Yes, ma'am.
Yes.
Yeah. So thank you very much for giving me this topic. In fact, I was asked to choose. And now we are shifting from a much commoner cancer, that is CA body uterus, to comparatively a lesser common cancer, that is CA vulva. Management of CA vulva is basically a surgical treatment. So I thought, let me start with a little bit of surgical anatomy of vulva. And I will be talking only about the invasive part, as the pre-malignant and non-invasive part will be dealt later on. So the vulva includes right from mons up to the perineum. It includes clitoris, labia majora, minora, and all the skin, all the subcutaneous tissue and everything. Like even if it is a vestibular gland, or even if it is Bartholin gland, or even certain sweat glands which are there in the skin, and also the part of hair follicles and all, they are all included in vulva. So many times even the melanoma of vulva or some other malignancies of vulva which are otherwise seen in the skin are treated as CA vulva. Blood supply is equally important, as we know that vulva is richly supplied by blood, like our face, and it's mainly the pudendal arteries. This is important because we want comparatively less blood bleeding during surgery. So here you can see that these vessels, they supply, or they actually are at 4 and 8 o'clock position during the lateral dissection, and one most important is at the clitoris. So these vessels need to be specially dealt with when we are doing surgery. Nerve, these pudendal nerves and all, these may be they get damaged during the surgery, especially during the lymph node dissection, and can lead to paresthesia of the areas. So they are also important. The most important is lymphatic drainage of vulva, and we must know that the lymphatic drainage of vulva, from midline structures, it crosses bilaterally. It crosses on both the sides. Initially goes to the superficial inguinal group of lymph nodes, and then later on to the deep, and then to the pelvic and higher up. So it is important. This is the fact that it goes on both the sides. The fact is important so that we can choose whether to go for bilateral lymph node dissection or unilateral lymph node dissection. This I will be dealing subsequently. And here you can see that we call it vein, artery, and nerve. This important arrangement is very, very important as far as the surgical anatomy is concerned. So this is how it is. You can see in this figure that there is crossover of lymphatics. They go to the superficial inguinal group of lymph node and then to the higher. So any lesion which is midline or within 2 centimeter of midline, they are to be considered as midline structures or midline lesions, and bilateral lymph nodes are to be addressed. This must be a little hazy slide, but it's just a simple classification, which is latest 2021 FIGO staging of carcinoma vulva. And let me tell you that majority of the tumors which we come across is in stage 2 and 3. Though it is, CA vulva vulva is an organ which is usually seen and accessible, but still women do not turn up for this. The age of this disease is also gradually going down, probably because of the HPV infections. So just the etiology, as you all know, HPV infection, smoking, and all these things. The clinical presentation is mainly vulval pruritus ulcer. This is, of course, one of the bad disease which I'm showing you. So what treatment options we have? I'm not going for the pre-treatment evaluation or what investigations are to be done before that, but we normally get at least CT pelvis, so that, right from up to mid-thigh, so that even the groin area and everything is visible, and we can know, we can know about the lymph nodes, status of lymph nodes in groin and also in the pelvis. And of course, the biopsy report is the most important treatment. So when we know that microinvasive disease is there, then ideally is radical wide local excision with 1 centimeter gross margin or even 8 mm of pathological margin is good enough. And groin dissection is not necessary, but as I said, we must know the histology, and we also should have a radiological evidence that groin nodes are not big enough. Early vulvar cancer means which are confined to vulva, stage 1B and lesser than 4 centimeter. We always have to do radical wide local excision or radical vulvectomy and appropriate management of groin nodes. So what is the appropriate management of groin nodes? We know that it is the most important factor which reduces the mortality. And the lymph node mets incidence is nearly 30%. We normally go for inguinofemoral lymphadenectomy. Sometimes we have an option of even sentinel lymph nodes. Sometimes they are bulky, big, so we also have an option of debulking. So how and what is appropriate when to do this? So tumor, all those which I said, less than 2 centimeter or crossing midline, large lateral tumor, positive ipsilateral lymph node, we have to go for bilateral groin dissection. There are certain trials. I have included this especially because many PG students are there. So this is one trial which evaluates the efficacy of sentinel lymph node biopsy in early stage. And this is what we normally advise our students, that they must, to start with, they must draw it, all the lines of incision and the femoral triangle. Here you can see that there is anterior superior iliac spine, pubic tubercle, and this is actually the entire triangle is a femoral triangle. So this femoral triangle needs to be cleaned up, and this is inguinal ligament, you can see, and you can see we have marked a femoral artery and also the area from where the incision is to be put. There are many people, those who put even J-shaped incision or a vertical incision and all, but we are most comfortable with this line of incision. And it is, the butterfly incision and all, they are all obsolete nowadays. We always do by three incision techniques. There are certain indications where you can do even sentinel lymph node biopsy when it is unifocal tumor, because sometimes you will have even multifocal lesions on the vulva. When tumor is less than 4 centimeter, we have less than just up to 1 mm of stromal invasion, clinical or radiological negative groin nodes. And they also say that it is to be done only in the centers, those who have experience and those who have precision. Like technetium-99 or methylene or isosulfan blue dye are preferred like all other lymph node sentinel lymph node procedures, but this is available only in certain centers only. I have included most of the NCCN guidelines because number of PG students are more, and secondly, these are all reproducible and these are always accessible. So if you go through all these NCCN guidelines, which are very simple, these are very, very simple, and they give you very perfect guidelines how to go about it. So like early stage, you have to have a biopsy report. If it is less than or more than equal to or less than 1 mm invasion, it is 1A. You can go for simple partial vulvectomy and observation. If it is more than 1 mm invasion, you have to go for lateral lesions more than 2 centimeters from vulval. You can go for partial vulvectomy and ipsilateral lymph node dissection, or even go for sentinel lymph node. But if it is anterior or posterior lesion, or if it is a central lesion, then partial vulvectomy or radical vulvectomy and bilateral inguinal lymph node evaluation and lymph node dissection is mandatory. I will come back again. What if the lymph nodes final histopathology, according to final histopathology report, what adjuvant treatment is to be given to these women? So we have the risk factors of histology. If all the margins are negative, I'm talking about more than 1 centimeter margin, or 8 mm of pathological margin. If they're all negative, we can observe. But if there are positive margins, we might there are chances that we can have even re-excision. So we can do re-excision, or if they're unresectable, then we have to go for external beam radiotherapy. Similarly, nodal evaluation, because adjuvant therapy is most important part of these patients. If the lymph nodes are negative, we don't have to have any kind of adjuvant therapy needed for these women. Lymph nodes negative and all the margins negative. But if sentinel lymph nodes are positive, then we have to have EBRT or concurrent chemotherapy. And it's usually a tumor board decision, because sometimes even we have single node positive, or we have more than 2 nodes positive. What else patient can be offered? Either it is only radiation or concurrent chemoradiation. So if it is an advanced vulvar disease, when we are talking about stage 3, 4A disease, usually in stage 2, when lower part of vagina is involved, it is usually possible to remove lower 1/3 of vagina. But when it is a higher disease, we can always remove even lower 1/3 of even urethra, but not beyond that. So in those situations, and depending upon the groin nodes, the treatment is to be planned beforehand. Sometimes the patients, those who have clinically suspicious groin nodes, even FNSC or the biopsy of groin nodes can be carried out, and retrospective analysis or certain survival benefit analysis in certain studies, they have shown that adjuvant RT or chemoradiation to these patients is mandatory. Adjuvant chemotherapy is also increases survival time and reduced mortality. So in advanced cancer, we have to treat a primary vulval tumor and the groin node separately. Primary vulval tumor is that we have an obsession of surgical excision, sometimes, without, with the clear margins and without sphincter damage, that I'm talking about the inner sphincter. If there are chances that sphincter can be damaged, even primary CTRT is preferred over these tumor modality. There are many patients we have seen in which we give primary chemoradiation and tumor shrinks to a great extent that only the biopsy is positive. Otherwise, it doesn't look like as if there was a tumor. Pelvic excitation and everything, probably now it is only in the books. I have, since many, many years, I have never seen pelvic excitation being done for CA vulva. But if it is close margins, as might happen in advanced vulvar cancer, adjuvant radiation treatment is mandatory. So this is again for higher, locally advanced. You can do, if the nodes are negative, go for positive lymph node or negative lymph node and additional treatment. And this flow chart is self-explanatory. But if unresectable nodes are there, irrespective to stage and all, sometimes inguinofemoral lymphadenectomy is not performed, and all these nodes are subjected to concurrent chemoradiation. If it is metastatic disease beyond the pelvis, as in stage 4B, we have loco-regional control or symptom palliation in the form of radiation, and we also have plus or minus systemic therapy, or in very, very advanced cases, it is just the best supportive care. So there is no role of lymphadenectomy in all these patients where the disease is beyond the pelvis, or it is a metastatic disease. So I said radical vulvectomy, radical hemivulvectomy, and wide cortical radical excision. These are the main, the surgical modalities for all these patients. So we have, just to summarize, stage 1A, wide local excision, and it's defined as removal of vulval skin with layer of subcutaneous fat under the tumor with a margin of 1 to 2 centimeter. 1B, stage 2, and some select stage 3 unifocal lesion. We have radical vulvectomy or radical vulval local excision, and we go for, in this, we go up to the inferior layer of urogenital margin, urogenital diaphragm, and with a free margin of 1 to 2 centimeter. And we do give consideration to spare vital structures like urethra and anal sphincter. So this is usually the outer incision which has been planned depending upon the size and the site of the tumor. And this is the usual defect after this, after excision of the tumor. The inner incision is to be planned once we do the external incision, and inner incision is planned whether we want to remove the lower 1/3 of urethra or not, and how much vagina needs to be removed. So in locally advanced disease or multifocal, we have to do radical vulvectomy with the entire vulva down to the layer of deep thigh, sometimes even up to the periosteum of the pubis. And exentration, I will not talk about it.
Excuse me, ma'am, time is up.
Yeah, I'll just go. So I will not discuss into the principles of radiotherapy as it is another domain. This Groins S is important. Chemoradiation and systemic therapy is also important. We normally use cisplatin or 5-FU as chemo. And this is the surveillance protocol for all these women. So thank you very much for having me here. Thanks a lot.
Thank you so much, ma'am, for such an informative and really updating lecture. Truly, I think we heard from horse's mouth. So really very informative, wonderful lecture. Anybody wants to ask any questions?
Thank you very much. Thanks a lot. Thanks for having me.
It was very elaborative, ma'am, on the vulval CA.
Thank you.
So we move on to session 4. We have a great panel discussion here. Sapna, you can call the moderator.
Yeah. So moving to session 4, it's a pleasure to invite Professor N. Sundari ma'am, Senior Consultant, Ramaiah Memorial Hospital. She is a retired professor at Ramaiah Medical College, a DNB teacher, and a president and founder of an NGO Mahati Trust. She has been doing enormous work in cervical cancer prevention awareness in Karnataka.
Enough, I think, Dr. Sapna.
Yes, ma'am.
Please.
Welcome, ma'am.
Already we are a little late, no? So let's
Yes.
go on to the thing. I feel I'm an odd person among all great gynae oncologists. I'm only a gynecologist, and preventive oncology is my passion, of course. And this is because of Anjana, who just pulled me into this. I've been listening and enjoying all the lectures, okay? Okay, thank you for involving me into this, and thanks for the kind introduction. Yes, Sapna.
Yes, thank you, ma'am. I welcome Dr. Anjana ma'am. We have been seeing her, and she's a senior
You can move forward and you can call other speakers.
Yes, ma'am. Yes.
Sorry, other panelists.
Next slide, please. Dr. Archana Dwivedi ma'am. She is the president of Baroda Obstetrics Gynec Society, and she is the president-elect for Midlife Management Committee, FOXY.
Thank you, Sapna. It is chairperson elect. Sorry.
Yeah.
Sorry.
Thank you so much for that.
So
Dr.
she has already promoted you. Congratulations.
Dr. Shruti Bhaskaran, ma'am, Professor, Department of OBGY, UCMS and GTB Hospital, AOGD, Web Editor, associated with NARCHI, Co-Editor AOGD, and she is a certified colposcopy trainer. I welcome you, ma'am.
Yeah, she's there, I think so, doctor.
Yes. And now I invite Dr. Nilanchali Singh, Associate Professor, Department of OBG, AIMS, New Delhi.
Yeah, we'll do that.
Clinical Fellowship in Gynec Oncology, Canada, a Gynec Oncology Group, GOG Fellow, USA, 2022-26, and a member of Working Group International Papilloma Virus Society and a fellow in colposcopy. She has many publications and a member of various organizations. I welcome you.
Next, you have to unmute all the panelists and Dr. Sonal Kotrawala.
Yes. So I welcome Dr. Sonal Kotrawala, madam, a senior consultant gynec and ART specialist, Ahmedabad, Kotrawala Women's Clinic, Ahmedabad, a trainer in endoscopic surgery since 2006. She is a state coordinator for contraception awareness, FOXY committee, program coordinator in school health associated with FOXY, many journal articles and papers in various journals, and a chairperson of many committees. I welcome you, ma'am.
I think so you have to unmute all the panelists. They are dead.
Can I share my slides?
Dr. Sundari, you have not been seen.
Okay.
Yeah. You can share your slides, ma'am.
Yeah. Can I share my slides?
Yes, ma'am. Dr. Nilanjana, unmute yourself.
Can you see the slides, please?
Yes, we can see you, ma'am. Make it full screen.
Yeah.
Till we are sharing the slide, I would like to congratulate Team ICOG and Anjana ma'am for such a hard work and making this program. You included everything and it was a great experience. I was glued to the screen all throughout.
So that all credit goes to Dr. Sarita and Dr. Parul Kotrawala, who were after me. You include this, ma'am, do this, and it was their brainstorming.
Anyway, I also have the same feeling as you said, really wonderful. All the credit.
Yeah, ma'am, your slide is seen, no?
Yeah, can you see the slides,
Yes,
please?
yes, ma'am.
Yes.
Yeah.
Yeah, this is one topic what we say is the no man's land, the vulva, because there are a lot of people, is it gynecologist? Now you have got a urogynecologist, dermatologist mainly because most of the things are because of the dermatologist will deal, and then of course oncologist as we know. Okay, why? Because the structurally it's a conglomeration of the skin, musculoskeletal, vascular, whatever you say, all the, so these ones are there in the vulva, as we know, though we see predominantly the skin, but there is all the structures are involved in this. So naturally the pathology will be multifaceted. So we need multidisciplinary approach sometime in few specific conditions of the vulva. Okay, now we go on to this is the cause for concern is the vulval problems are increasing, both benign as well as malignant, as previous speaker has told us about the vulval cancer. And it was one more thing is, it was almost like, neglected subject. You ask the postgraduates also, we don't take any class on vulva because we never used to see the vulval diseases very commonly. And of course, now what's happening is the lifestyle in younger generation, this is causing the HPV virus and a lot of infections, and then multiple sexual partners and the other sexually transmitted diseases, nagging and the vulval diseases is increasing. And as the longevity increases in a postmenopausal woman, we know the conditions which they would get it into all the chronic inflammatory problems of the vulva, which again leads to the cancers. Okay. Now, this is what we are going to do. This is a very small, common conditions. What about the vulva we are going to deal with. Nothing hi-fi here, very practical things. So we do recurrent vulval problems and pre-malignant lesions, that's all. And we have heard about the cancer vulva. We are not touching at all the cancer vulva. Now, this is a 35-year-old lady presents with intense itching, burning and discharge from vagina. She has come to the outpatient. She had treatment 3 months back for similar complaint and was treated with a relief of symptoms. But unfortunately, she gets back a symptoms again and she comes to Dr. Archana. What is your diagnosis and what would you like to do for her, Dr. Archana?
Thank you, Sundari ma'am and Anjana ma'am. This is a very routine day-to-day gynecology cases which comes into our OPD. There's a thick curd-like discharge, typical cottage cheese appearance. You can see the skin is eroded. So I think vulvovaginal candidiasis would be my first diagnosis, and any skin condition. There are a little bit of, like, you can say, the pustules, or you can say blisters also there. So we can have herpes, or also can be one of the infection symptoms as well.
Oh, good.
Maybe
Okay.
an allergic contact dermatitis, maybe because of any cloth allergy, or maybe some use of various products available in the market. So dermatitis is again important.
So, as you thought, one of the things, it was a vulvovaginal candidiasis. Next problem is she had treatment, and again she comes back with the same. So now we need to know what is the recurrent candidal vulvovaginitis. Is there anything called a chronic vulvovaginitis? I mean, we need to diagnose it, and we give a label it as one of these three things, because our treatment and the investigation modality may change, right?
Yeah,
So
perfectly, ma'am.
what is recurrent and what is chronic and what is complicated and uncomplicated? Anjana, will you be able to take it up?
Yeah.
Dr. Anjana is here.
Yes, she's
Yes,
there.
Dr. Anjana.
Yes, ma'am. Let the doctor.
Is it too
take
simple
it.
for you? You want somebody else to take it?
Okay, I'll take it, no problem.
Yeah,
So-
anyone, probably I don't ask, I think any one of you can take it up. We
I'll
have
take it,
certain
madam. Actually, the
scenarios.
case which we are presenting is coming in 3 months, so she cannot be termed as recurrent vulvovaginal candidiasis.
Yes.
Recurrence means at least 3 to 4 episodes in a year, unrelated to antibiotics, and it should be proved by culture, I would say, or a wet mount. At least in one, we should have abundant amount of heavy growth of candida, like pseudohyphae is seen. Chronic is when the symptoms go on persisting, say 6 to 8 months. And complicated is always more common when we see the patient is having any comorbid conditions, she's having immunocompromise, and the most worst part is non-candida albicans. That is only 5 to 10%, but it is the most difficult to treat and comes as a complicated vulvovaginitis.
Yeah,
Keeps
after
on
the
coming up.
chemotherapies, now that the cancers are prevalent, and she's on chemotherapy, and then of course pregnancy, we don't say it's a complicated, because during pregnancy it may happen. Now, as you said, say 4 or more episodes means once in 3 months is okay, no? That may cause it. Within 3 months, that means she has come second time. Could we put her as a recurrent vulvovaginitis or not yet?
No, no,
Because
not
we
yet.
have
I
seen
say
her
no.
for 1 year. Okay, good.
Not yet.
Now, what is the cause for this recurrent vulvovaginitis, you think? I mean, we know the cause, but for the recurrent vulvovaginitis, we
Yes,
would say what are the causes?
The important thing for nowadays scenario is that use of ample use of antibiotics without completing the course.
Very
Patient goes from
wonderful
family
point.
physician, and there are so many defaulters nowadays with online therapy. They just have to book 1 or 2 antibiotics, and the symptoms are partially relieved, and things are gone. And there is one ointment given to the mother is followed by everybody. So I don't know that ointment is going to benefit her or not, but this ointment is the main cause of antibiotic resistance as well. And as you rightly said in your first slides, that young girls, the outfits, what the tight fitting clothes, unbreathable clothes, I would say, lots of perspiration keeps on collecting, and the fancy washes, the deodorants, there are so many things. Peer pressure also teaches them to use. And very commonly, you said pregnancy can be one condition. Compromised immunological status, HIV status, many people are not even detected, and they can come as this problem. Vaginal douching is something which has become a very common habit. That can also be one of the reasons. But I think if I have to say diabetes is on rise, comorbid conditions, but if I have to label as the most common, that is defaulter and misuse of the products which are shown in the social media.
Those are all the causes, what you have said. The main thing, if you take, what happening is, because you are rightly said that lot of douches, lot of perfumes
Yeah,
are
what
being
is
used in the
happening, if
vulva.
you want me to tell that, ma'am, there is a biofilm which protects actually.
Yes.
Vaginal pH, and the biofilm which protects the vagina inertly and inherently, which is already there. We never put any washes in our eyes and wash it. That is what I tell my patients. I don't clean my inner buccal mucosa by the soap and this thing. So when you're using or misusing the products, the biofilm gets destroyed, and the bacteria and the fungus gets actually entrance into the tissue. And H2O2 is what is a byproduct of lactobacillus, which is already present in the vagina. So whatever things are destroying or causing a decrease, even a hyperglycemia conditions are there. Immunity obviously plays a role. So these basically.
Yes, Archana. Archana, we have to be a little short because we have less time and we have more case scenarios. Probably we have to be a little short and
So
brisk.
basically, I would say biofilm destruction is the main cause.
Yes, main thing is that what you said. And one thing for all the postgraduates, whatever, please don't discourage all your patients and even yourselves not to use any of this V washes and any of the perfumes on the vulva and vagina because it changes the vaginal microbiota. And so what happens is fungal dysbiosis will occur. So, Candida albicans is one of the commensals in the vagina. And even in a pap smear, if you see, there is a fungal candida infection is seen. Unless patient is symptomatic, we don't treat it because it is one of the commensals in the vagina. We have to remember that. Okay, that's elaborate. Now, these are the things which I just skip it because we don't have time. See, this is beautifully the lactobacilli which are
Good thing I came across, Sundari ma'am, when I was studying on this, that people who are having A and B blood group, they have inert ability to prevent vulvovaginal candidiasis.
Exactly, because there is a genetic predisposition is one of the things they say that includes your risk group. Wonderful point you have brought it up, ma. So this is the lactobacilli which is there, which protects and then prevents the infections. Once we lose it because of the many things what Dr. Archana has brought out, this is the result of it and the balance goes off and they get a recurrent infections. That's it. Now, what specific history to be elicited? I think you have said elaborately all these things, the history. Shall we skip it?
Yes, only one thing which we have to take account is sexual activity, which is actually very underreported and not actually quoted when we go to the data. But having multiple sexual partners, having a poor perineal hygiene, and especially when the male partner is a sufferer, ladies can be a silent sufferer. This is the only thing. And OCPs, which we did not highlight, these are the 2 points.
And a very frequent sexual activity also is a
too much of
factor which can, promote this infection. Now, do you want to do any investigation on this woman who comes with a recurrent vulvovaginal?
Actually, ma'am, a good wet mount is fair enough. If you don't get wet mount any the evidence of fungi, you can go for culture. But there is a recommendation of doing a PCR test also, which is not actually FDA approved, but can be offered to patients because nowadays we have to treat as evidence-based medicine. So I think a good wet mount is fair enough where we can add 10% of KOH. Because important thing is the vaginal pH is not disturbed in candidal infections.
Basically, ma'am, I think if a woman is coming with such type of infection, we need not do any testing. We can straight away give them treatment.
Yeah.
But if there is a recurrent or that, then we can go for testing and see.
Anjana, we are talking about only recurrent infection. We are not talking about the first time or second time she has come. We defined the recurrent infection. When she comes with the recurrent infection, probably we need to do some investigations because the commonest thing, Candida albicans, may not be the cause for it because non-Candida are all resistant to the usual treatment of fluconazole. So that's why we need to go for a culture here or a PCR if it is a recurrent infection, right?
One thing
so of course she said that KHO and then what you see budding or hyphae. Yes, ma'am. Go ahead.
Why do we add KOH 10%? Because the normal vaginal pH, if you add this, it becomes alkaline. So things start showing up properly rather than going for a simple wet mount. So
that is what
nobody can help us diagnose.
Yes. Now, how do you treat a recurrent vulvovaginal infection now? Yes, the treatment of recurrent.
So I think azoles are there always to help us out.
Yes.
Topical and vaginal pessaries. I think we all are using it rampantly, 100, 200. There are like, I have no experience for this new one which you have mentioned, but definitely things are coming up. But most commonly, myconozoles, itraconozoles, and fluconozoles are helping us a lot. You have very beautifully described over here. So
boric acid, ma'am. Boric acid is
this is one thing which
boric acid is something which has come up in the Indian market now. When I was taking a talk on the same thing few years back, it was not available.
Yes.
So what they say that 600 milligram, even if you give for 14 days BID dose vaginal insertion,
single dose is enough. Not BID because it has little side effects also. Irritation will
Yeah,
be
but
there.
recurrent you can give them, ma'am, and during the period, especially if you give them to insert once daily, that
Yeah.
is most helpful. That has
This
been
is very effective because I've been using it for a recurrent, not just once or twice. If they come recurrent infections, not getting rid of the infection, tried all these things. Boric acid does a wonderful job. Okay.
One
This
thing
can
which
be
is more to be added is like vaginal probiotics. That is very good because you restore the biofilm by using that. Sometimes patient asks that you have given us the pessary to insert. So when do we insert that? So practically, once you insert the pessary, after that 2 to 3 hours, you can insert the vaginal probiotics. So
probiotics.
say afternoon you insert the pessary and evening you can insert that. That can be practically possible.
Should husband be treated? Sexual
Not
partner?
required. Not required, madam.
Not required. Okay. That's wonderful. I think we have the gist of recurrent vulvovaginitis. Now we move to the second case. 35-year-old presents with the multiple lesions on her vulva for 3 months duration. She has no pain, but it's really disturbing her. Now differential diagnosis. Who will take it up?
I will take it up, ma'am.
Yeah, please.
Yeah. Such type of lesions may come when there is no painless, then we always try to think of vulval warts and we have to accordingly treat her accordingly.
What is the important history you should be eliciting in this, Sanjay?
The first important history is to have her as what we can say the status of HPV vaccine or status of sexual activity, an immunocompromised state, and it is a clinical diagnosis and STDs. These are the main histories which has to be taken, and HIV infection.
Yeah. Okay, this is what we have to take immunocompromised status and HIV infection because they may not come out with that because they can have a repeated eruptions of this warts. So we have to go in. And one thing, important thing is when we have these warts, probably we may have to extend our surveillance onto the cervix and the vagina also. That's very important. We have to remember.
We also have to look into STDs.
Yeah. Is there a role for biopsy in this patient?
No, no,
It's a clinical diagnosis, evident, we know. But
yes.
should we, anyway, there is a role for biopsy, Dr.
No, no, there is no role of biopsy. You can
Okay.
treat it any other direct way. If you can see a 1 or 2 warts, you can directly treat it. But
Yeah.
if they're recurrent, then we have to think of biopsy.
Yes. Recurrent or if they are resistant to the treatment, whatever you have given.
Yes.
And the
yes.
lesions are not looking very typical. Sometimes, warts you can just make out. I had in some incidences where, warts were not looking very typical. Then probably we may have to do biopsy because not to miss anything else. Of course, the neoplasia is one concern for us, not to miss it. So we may have to go for the biopsy. How
And
do
if
we
you have
treat this
a
patient?
discoloration with a warts, then definitely you go for
Yeah.
biopsy if you are having VIN or
Yes.
pre-invasive lesion.
Yes, Sanjay. Now, how do we treat these patients? It's very simple, but
it's very
if we get
simple, ma'am. You can go for excision or you can go for local. There are many things. There is a local, what we can say,
depends on number of warts.
Number of warts.
Number of watts, and then what is the
Local
area which is
ablation therapy,
involved? This is not.
cryotherapy applications, and lots
Yeah.
of there. If there is a fluoride wart, then definitely you have to go for local application, which are Filin and imicurmode, which is very common. And the skin specialists, they use tricloacetic acid, TCA, what they say.
Yeah.
Especially if they come to us as a gynecologist, we go for laser ablation, or you can go for even a small lip biopsies for doing this type of treating this type of infection.
Okay. In my experience, I think the cheap and best is the trichloric acetic acid. I get it made 10% trichloroacetic acid. I just apply to the warts, only the base of the warts. They just fall off within 2 to 3 days. When there are multiple warts, and then maybe a surgical excision and all may cause a real problem for the vulva. So what we could do is we can go for these applications. Of course, Podofilin is there. Trichloroacetic acid, one advantage is even in the pregnancy, if there are too many warts and then patient is really uncomfortable, we can use this, whereas we can't use podofilin during pregnancy. So that's yes.
Yes, ma'am. Yes, ma'am.
Okay. Is there a role for conservative management in this wards?
Definitely, if it is involving the whole vulva or it is involving the what we can say larger area, then we can definitely think of doing. And if these warts are going to get resolved, you can definitely go for conservative management. Few in number, whatever you have mentioned on the slides, ma'am, then definitely you can go for.
Suppose we see her on examination, but she doesn't have any discomfort and we see few warts a day. Probably we can mention it to her and say that you come back after some time and see whether they would have regressed. Okay, that is what we can tell her. Unless she's symptomatic and the warts are too many. The giant warts, I think how many of you have seen? I have seen a giant warts, entire vulva and the perineum. This is very uncomfortable for the patient. Probably in that cases, definitely we have to go for some method of treatment. What is the chance and frequency of recurrence in these cases? Yeah, recurrence is very high in the wards. Whenever you're treating it, you have to tell them that you may need to come again and again. It will take time. And sometimes it will take time to, you have to do 2-3 sittings. It may you need to have follow-up at least for 1 or 2 years to get complete remission of wards. But the recurrence are very high. So you have to guide them that way. You have to counsel them. And even the sexual partner has to be counseled because they may also have warts and they need to examine the sexual partner also. See, the HPV virus is dormant in them, and then now and then it goes on flaring up and causing the warts. That's why the recurrences are very common because we cannot eliminate the virus there. That's a problem. Patient comes back with extensive warts after 6 months and is seropositive for HIV infection also. What are the problems we are facing in her and how do we deal with her? For her, ma'am, I think so. We have to look into 2 things: her HIV status. We have to treat her HIV infection also, and we have to simultaneously take her warts. Treating HIV infection alone will not cure her warts. Both have to manage differently. Yeah. That's what we have to remember. She asks now. She's frustrated. Can I take vaccine, madam? Will it help me at all? Because she's really frustrated now. She'll ask you what's the answer for her. Ma'am, definitely she can take a vaccine. It reduces chances of recurrence. And my personal experience, I had one patient coming with warts and I give her HP, then after she has not come for follow. So probably her warts have gone. So definitely the vulval warts is the one of the things which can be controlled by only HPV vaccine, ma'am. It is nearly 100% we can say having response on the warts to prevention of warts. If I cannot say for controlling of warts, but prevention of warts, HPV in vaccine should be recommended to all of. Yeah, that is true. And of course, unfortunately, she had it. Even then, she has some benefit of reducing the recurrent chances if she takes the vaccine. That's good. What are the recalcitrant warts? Recalcitrant warts are those which comes up. Yeah, those are do not respond to the treatment and they come over a period of 6 months. So we consider them as a recalcitrant warts, man. And we don't know what to do for them except that giving a treatment, local treatment whenever they have it. Thank you very much. Now this is the third case. 30-year-old presented with this vulvar lesion for 4 days duration and she has a pain and burning sensation. The diagnosis menu, who is taking it up, please?
I'll take it, madam.
Yeah, please. Sonal?
Yes.
Please, Sonal.
Anyway, thank you. I think pain is the main symptom. Then we always consider herpes as the first, even everywhere in the body because the neurologist is involved now. And here the typical painful, typical fluid-filled vesicle type of structure. Sometimes we do have to differentiate with candidial, but this kind of the picture which you have shown is classic herpes. Okay. And along with that, if it is severe, I think lymphadenopathy will also be there, inguinal lymphadenopathy, most of them. So patient complaints of pain, burning, and quite often, typical sexual intercourse before 7 to 10 days, which was the main cause for this infection. Because
So there's a typical infection, you think. Now the problem is, should we confirm this diagnosis or is it okay clinical diagnosis for us?
See, there are tests available, blood tests are available, serological tests. So we might as well give the test for that specific HSV1 and 2, both we can do. And biopsy, I wouldn't suggest to begin with. If it is recurrent, then only. Otherwise, with this test only, and we can start with antiviral treatment.
Very right. Okay.
So painful patient is so much worried about it. It's not like warts that she can wait for a day or 2. Here we have to give immediate treatment. That is why.
Okay. So if it is clinical diagnosis, we are very sure just straight away go and give the antiviral. Otherwise, probably. we may
Yes.
have to do some tests to confirm it. If the patient is very fussy, as you say, do
Yes.
you think it is true, it is the herpes, then probably we may have to. Then how do we treat her?
See, I think we all have been using acyclovir since quite some
Yeah,
time.
yeah.
100
Now
milligrams
it's, I
3
think,
times a day. Yes.
dermatologists don't use the acyclovir.
We
They are
all
trying to-
gynecologists use acyclovir.
Because
Once we
this is
try the
for a 3
topical
to 6 times, yeah, we used to give. Now it is, I think, a BD dose. What they prefer is because the patient comfort, not rather than taking 3 to 6 times a day, they take valacyclovir this 2 times a day.
times.
Probably they
Yes.
use. Now the important thing is the first clinical episode, and then there is a recurrent episode, then the suppressive therapy. There are 3 types of therapy for this.
Yes.
Now, the recurrent episode therapy would be the same drugs probably we can use
For
when she
5 days.
gets it.
Yes.
Once if it recurs, now what do we do? Second time she has come back with again the same thing. Now what will you do? You have treated it. After that, anything else we have to do, Dr. Sonal?
I think this time we might take a biopsy just to confirm the diagnosis. And
Yes.
then again, we have to give the antiviral treatments. In
Yes.
fact, say that you have to give it for continuously for 6 months at times.
Yes, yes. That is a suppressive. Suppressive therapy we may have to give because
Yes.
she comes back again with that. As we rightly said, yes, we have to confirm it with the biopsy because we may be missing something there or it's a wrong diagnosis. And then if it is confirmed, you go for the suppressive therapy of any of the drugs which is convenient for the patient. In a HIV patient, how do we manage the same problem?
HIV is always going to, cause more symptoms. It is going to be more
Aggressive
virulent kind of.
patient,
So
yes.
patient has more problems, and this shedding is also more. So because of that, the patient same treatment we are supposed to give, but
Yeah.
along with that, HIV is to be treated. And
Yes.
I think Olen, this new antiviral which you have written, I do not know about it, frankly. Maybe skin people are using it, but this
is
patient
acyclovir
require
resistant.
prolonged
Yeah.
treatment. Yes.
Yeah. If it is acyclovir resistant, probably dermatologists go for pseudofovir.
Yes.
That is the latest, I think, for especially patients who have got HIV plus the recurrence of the infection. That's it. Now this is usual thing what we see, 62-year-old lady coming with itching, dryness and external genitalia for 2 months. No discharge for vagina. She is para 3 and then the last childbirth was 30 years and menopause 10 years. Known diabetic and hypertensive, and this is the picture what you look at when you look at the vulva. This is the picture. Who is going to take up? Shruti or Lan?
Yes, ma'am, I can take this up.
Okay.
Nilanjali, yeah.
Nilanjali, you want to take? Good.
Yeah, so this it's a very clear-cut picture of lichen sclerosis. There's loss of differentiation between the labia minora majora with erythematous lesions, and there are some scratch marks appearing red. So this looks like lichen sclerosis. That would be my first differential, but of course it is, and there seems to be a narrowing of the introitus too. That also goes in favor of lichen sclerosis. But since it is also, there appears some erosion, so I would still not completely just rely on my clinical finding and may go for further investigations, for example, a
This
biopsy.
may be advanced, whether see that the clitoris and all has been not there, it's all fused here.
All fused.
And they come with a labial fusion. I have a patient who recurrently comes with a labial fusion. If you all think I'll separate and send her. Now, what are the classification of the vulvar premale here? Because a lot of confusion, why we don't want vulva to be taught or to be read is we have a confusion because of a lot of terminologies and classification. Now, luckily it has been very well simplified, especially WHO. Could you just tell us what is the simple way of classifying vulvar premalignant lesions? Nilanjali.
Right, ma'am. So vulvar pre-malignant lesions can be epithelial type, for which you have shown the classification, and there can be some non-epithelial types also.
Yes.
For example, pre-invasive melanomas, or what is called melanoma in situ or Paget's disease. So they are the non-epithelial lesions. But then there are more commonly we see the epithelial lesions, epithelial pre-malignant lesions. Like you rightly said that the WHO has simplified it and it has just labeled it as HPV associated and HPV independent. The HPV associated ones can be the low-grade squamous intraepithelial lesions like WIN1 or WIN2 and 3, which are also called usual type WINs. Now, these are more common in younger women. Then the HPV independence ones can be the most common will be the differentiated WIN, which is associated with lichen sclerosis. And there are some other variants also of HPV independent types, like what is called the DEVIL, which is differentiated exophytic VIN, and then VAD, that is the vulvar acanthosis with altered differentiation. So these are various types of vulvar intraepithelial neoplasia, which is slight modification from the ISVVD, because at a lot of centers, even ISVVD classification is also used, which was given in 2015, and is just a slight modification that it says DWIN, UWIN, and then it talks about the HPV dependent one, that is the low grade. That is low grade, high grade WIN, and then the dedifferentiated WIN.
Main thing here is we have come out of VIN 1, 2, 3. Now it is only HSL and LSL, like lower anogenital squamous terminology has been used. According to that, it is again like uniformly, it is everywhere, cervix, vagina, vulva, LSAL and HSAL. LSAL, we don't bother about at all because it's only related to HPV. It denotes that it's HPV infection, so we don't need to treat LSAL, but only thing is HSAL, we need to treat. Correctly, you have said that. Okay, this is what again we said, and what Nilanjali has said. This is the one. I think.
Yeah, a very important point to add will be, ma'am, that the WIN usual types, they have less progression to invasive cancer as compared to the differentiated types, which has a very high risk, 50 to 80%. And the usual types, they can go in less than 20%. So that is the difference between the pre-invasiveness of these diseases.
Here also now IHC has come into picture here also in vulval cancers, probably P16 and Ki67 positivity. All these things are very important now to know the prognosis and recurrence rates. Okay, how do we proceed with her? Now you have seen this patient, and how are you going to, what are you going to do? Straight away you start treatment because it's glaring at you, and it's you said that it could be lichen sclerosis. What are you going to do otherwise?
Yeah, so though it appears to be lichen sclerosis, but then as we talked that there can be pre-invasive lesions in lichen sclerosis, like the differentiated WIN. So I would not just go with direct treatment. I would like to go for a detailed examination and a biopsy. So as pointed in your chart, ma'am, that we have to go for a detailed history, this duration of symptoms, any associated long-term diseases, and then we can do examination, not just a naked eye examination. We can also use the aid of vulvoscopy, colposcopy, and then we can do thereafter, after identifying the lesion exactly, we can go for a biopsy, which will give us a better result.
Wonderful. So I don't think we need to go for the steps of vulvoscopy. You have mentioned it. Okay, and a very important valid point you get it is everybody just puts on all sorts of ointments they give and then send the patient. So the whole picture will be different when they come to us. So initially, yes, we have to do thorough examination, and a biopsy is mandatory to rule out DVIN. Okay, now these are the vulvoscopy. Now, what is the sensitivity and specificity of this vulvoscopy? Cervical cancer, yes, we know for the cervix colposcopy. But what about vulvoscopy? What is its sensitivity, and is it useful at all?
Yeah, definitely. It is very useful. And vulvoscopies have high sensitivity, or some more than 90%. And specifically when we evaluate the 3-ring vulvoscopy, which actually identifies the 3 areas of the vulva, and then we specifically look at those areas, then the sensitivity has even been reported to be, nearing 100%, which is really high. And then, of course, even the specificities are very high and more than 90-95%. So it is a very good method. And the only difference between a colposcopy and vulvoscopy is that after application of acetic acid, unlike in colposcopy, which we just wait for 1 minute, here it is the skin, which is multi-layered. So we have to wait for a longer duration. And what we do here is wait till 5 minutes usually.
5 minutes. So 5% only we use acetic acid here, not 3%. And then wait, as you said, for 5 minutes to get the changes.
Right. And the change will be usually white lesion again, white lesion. And we can biopsy that lesion to get histopathology and manage.
One more difference is we don't get the vascular pattern as we get on the cervix here. but it's only we can see the abnormal areas, white patches, definitely we will see, which looks more serious to us. Probably those are the areas which we need to biopsy. Wonderful. Okay, ma'am.
Madam, little bit you do it fast because we want to even take the next case.
Yeah. See the valvoscopy, then you do the biopsy. It could be punch, it could be incision biopsy, keys biopsy, punch biopsy is very handy to take the biopsy. Yes, we can do that. Now management for it.
So if the biopsy just shows lichen
What do you
sclerosis,
do? If it is DVIN, unfortunately your biopsy says DVN, what do you do?
so lichen sclerosis can be managed conservatively, and the most recommended treatment is, or the treatment of choice is, ultra potent topical steroids, which is clobetasol propionate or mometasone furoate, and most commonly clobetasol is used 0.05%, and it can be given BD for 2 weeks followed by weekly, and it can be even given like 2 weekly later on. 6-month optimal treatment is
We
usually
shorten
given.
it, yeah.
Yeah, so that is what we can do. And then there are multiple other options. Surgery is only indicated if it is associated with DVIN. Whereas in DVINs, as we discussed, that the risk of squamous cell carcinoma is really, really high. So surgical therapy is the mainstay, and excisional wide local excision is something which is recommended with a margin of 0.5 to 1 centimeter.
Good, wonderful. Okay, now this is the last case, probably, maybe one more is there. 43-year-old presents with a burning, itching vulva, and she's only 43 years. Last 20 days, she has used the local application and oral tablets with a little relief. She has taken antihistamines and the local applications, antifungal, everything she has used. Her cycles are regular and no comorbidities she doesn't have. And this is the picture what we have. Who is going to take it up?
Ma'am, me. Good evening, ma'am.
Yeah, good evening, Shruti. Yes,
So, as we can see,
what do you
yeah.
think?
So this seems to be like it's a multifocal disease, and it is involving both the labia minora as well as majora, and somewhere I think I can see even hyperpigmented lesions as well. This seems to be with plaques. These are plaques and sharply marginated.
Yes.
Could be a VIN.
Red.
Some sort of VIN.
Hyperpigmented white patches.
White patches, yeah, and plaques, raised areas, sharply like.
Do you do colposcopy or do you do biopsy? What do you want to do to give a treatment for her? What
Absolutely, ma'am. When I'm suspecting VIN, I would like to do a colposcopy or a vulvoscopy for her.
Okay.
Vulvoscopy helps in the way that we will know the full extent of the lesions. If there are small lesions, that will not be missed if you're doing or seeing the vulva under magnification.
Okay.
And applying acetic acid also makes things much better to look at. And then it will also focus the area which is much severe from where the biopsies have to be taken.
Okay.
So vulvoscopy.
Colposcopy when you're doing vulva, please
Absolutely,
look at
ma'am,
the
in this
cervix
case,
also.
because
So
it is
you
a
have done it, biopsy is done. It comes as a UVIN or HSIL. What next?
So in this case, we have to know that now we have to treat. We cannot just leave her. So there are two options. If ma'am, what they say is, if you are suspecting invasion, the best treatment would be to do a wide. When we are the report comes as UVIN, but there is a suspicion it could be invasive also. Better to go with a wide local excision. And if we are very sure it's a small lesion, it is UVIN only, then we can go for other medical management therapies also, because it is anatomically much better and it is less disfiguring. Like in young patients, where it's a large area which is involved with, like in this case, where wide local excision can leave a very like a mutilated appearance, there we can even go for a medical management with imiquimod. So that is how we go with it, ma'am.
So if it is HSIL, surgical is the main thing with the, of course, a margin of 0.5. If it is multiple lesions or a younger age group, all those things, as you said, probably we go for the medical. In the medical, imiquimod is very effective. It may be used for this. Usually what is recommended is imiquimod. Probably for a longer time we have to use. Okay.
It's
And
4-5 months.
Yeah. And does she need HPV DNA testing, this lady?
Yeah, we can do it, ma'am, because we will have to go for cervical cancer screening. Like we have to follow her up with cervical cancer screening, and we have to look for any vaginal lesions. So by knowing that if she's HPV 16 or 18 positive, then it will help us in further managing her.
Yes,
So
we
yes, I
have
would
to
like
do
to
it
go
because
with
this
it.
is also HPV DNA positive. So we have to know, then we have to, of course, HPV DNA test, because all this can happen. So we need to do the HPV. What is the follow-up protocol for her? You have done the treatment, you have given the treatment. What is the follow-up now?
So post-treatment, once we have evaluated her that there are no residual lesions, we can call her after 6 months, and then
Yes.
after 12 months do a vulvoscopy.
Yes.
And if it is fine, then annual follow-up has to be done with
Yeah.
again vulvoscopy and symptoms, etc. And at the
Because
same time, we have to look for the
chances.
cervix and the perianal area also.
Oh, that's good. Follow-up therapy, I think you have said it. Recurrence is high, so we need to follow them up. Probably for a longer time, we need to follow them up. She wants to take HPV vaccine now. Is it useful, and what type of vaccine she has to take now?
Definitely, ma'am. We have to offer her HPV vaccine, and nonavalent vaccine is what is preferred for her, which
Yes.
will protect her from other like genotypes.
Because vulva is 16, 18, and 33. So that's why we have to give a nanovalent vaccine. It may prevent the recurrence. Chances can be prevented by that. Pre-malignant lesions, can they be stopped? Can they be prevented? Vulvar pre-malignant lesions?
They can be the HPV vaccine is the solution for this, ma'am.
Yes.
It will definitely help. Then lifestyle modification like stop smoking, multiple sexual partners, vulvar hygiene.
Yeah.
And of course, tell the patients every time to do a self-vulvar examination in front of like keep a mirror in front.
First examination, we have to tell them because it's approachable and they can see. We have to tell them to have a self-vulvar. Any change in the color or when they feel it, any change in the texture, they have to go for a doctor. And for all of us, for the postgraduates, especially if they are there, routine gynecological examination, don't just blindly put a speculum and look at the cervix, but please, before putting a speculum, look at the vulva once, and it goes a long way in diagnosing and preventing vulvar pre-malignant lesions. Okay, that is what we need to know about the awareness and all. Thanks a lot. And then vulvar clinics have been started. And then exactly only for vulval problems, there are dedicated clinics now. I think it's not very popular in South India. I think in Bombay, they have started. Do we have time, Anjana, or shall we stop here?
What is, because there was a message in the group.
We'll stop it. There is no problem.
I think so. The 6 minutes is showing, madam. We can take the last case. And
Yeah.
then
Okay. This is 74 years, has been having itching and burning of the vulva since 1 year. Local applications with no relief. The lesion on the vulva is seen, biopsy is done, and it comes as a Paget's disease of the vulva. Now, what are all the concerns? Who will take it up, please? Quickly.
I will take it, ma'am.
Yeah, ma'am.
It's a very
Okay.
rare disease. And when there is a Paget disease, we have to look into the whole screening protocol. These are the cases where a PET scan is really needed because they may be having a disease somewhere else and it is presenting as a Paget in the vulva.
Yes.
So we have to look into bladder, rectum, breast, and we have to find out underlying adenocarcinoma. Recurrence are very high and treatment is also very complex.
Oh God. Then what do we do for her?
Treatment management is, madam, if there is, we have to take an enough biopsy from the Paget whenever you're doing. Either you have to take a simple or you have to do take a biopsy which has a normal skin and a good depth. So a pathologist can report it. And the treatments are depending upon the lesion, go for radical surgery or you can go for, if it is not operable, if it is involving the anus or it is going the vagina or urethra, you need to go for medical therapy or chemotherapy and then later on go for surgery. It is a combination of treatment.
Okay. Okay, recurrence chances are very high. That's all I think. This will stop it. This is a pain in the vulva. Commonly, we don't address. What is the probable diagnosis? She comes with a severe pain, but there are no lesions on the vulva. You call it as what? Any one of you quickly? Just 1 minute.
I think that is vulvodynia.
Yes, good, wonderful. Vulvodynia. And vulvodynia and vaginismus, how do we differentiate? It's very important.
Usually vaginismus is, for the, they have problem with the coitus or intercourse.
Yeah.
They're the girls who come to us right immediately after marriage or something.
Yes.
And there we treat it with the glass dilators and local anesthetic agents and all that. Whereas in vulvodynia, I think the burning is so much and perimenopausal area people also come with vulvodynia.
Yes.
I've treated one patient with local application of injectable local anesthetic agents.
Okay.
Just to give her a little bit of local anesthetic agent and slowly it improved. Maybe along with that psychiatric treatment was also going on. So I don't know. We had to give her that also.
Yeah, treatment, as you said, these are all the treatments. So that counseling is very important, as you said, psychological and medications, maybe local applications are even antidepressants also have been tried. And local anesthetics, injections, and then the nerve blocks. Yes, these are all the things.
Okay, I think it's a concept. So vulvar lesions have varied presentation. I think all of you will agree that all the panelists have done wonderfully well, and they brought out very important points in a day-to-day vulval problems. Thanks a lot for all of you for really making this one very easy and very effective. And because all of you, it has become, I think, okay and meaningful. A panel. Thanks a lot, and I thank Foxy and ICOG and mainly Anjana to pulling me into this August real wonderful webinar. I have been listening from evening, and I thought I'm an odd person, but still she made me do something so that I feel good. Thank you, Anjana, for that. You're very kind to me. Thank you, all of you.
Thank
Thank
you.
you, Sundari ma'am and Anjana ma'am. It was really a learning experience for so many good things came out. Thank you so much for making us a part.
Dr. Sundari,
Thank
your
you, Dr.
slides were
Neha.
very excellent and you shared it with answers. So it was even a good for us to learn, recall our what knowledge, because certain things we do it, but when to come to speak on the topic, we fumble. So you made it very easy for us. And one thing I want to highlight about Dr. Sundari, she was the person who used to go in the villages. She used to sit under the, she told me, I was shocked, under the tree, and she used to call people for doing I think so, pap smear testing, and that took her a year, and now she is able to do lots of testing. Madam, it was a wonderful you shared me, and I think such type of things should be highlighted, that people work, they are silent workers, they never make a noise, and they keep on working at such a great level.
Anjana, thanks a lot for your kind words. I continue to do it now. Okay.
Yeah.
Okay.
Actually,
Tomorrow
I
I'm going
also
again
wanted
to
to say
village.
the same for Sundari ma'am. I've heard a lot about her. Silent warriors, you would say, but she has contributed a large. Thank you for having us.
Oh no, Archana, it's too much anyway. Thanks a lot, but it's too much for me.
And
But
before,
anyway, a simple way, just something to society. I've been, I'm passionate in that preventive, especially cervical cancer. So I've been doing it. But thanks a lot, all of you. Okay. Again, I thank all of you, and then I think we'll close it.
I
Thanks
think before we close,
Stop
Anjana ma'am,
sharing.
just a quick recap from you that you are using the DNA aneuploidy testing. Just have few words till they share the post test on that.
Okay, Madam Police, sir. This is a DNA ploidy test, ma'am. I think so. This is not okay. I can talk about it. It's a new test which has really come up, and it is a genetic test. And I've been using in one or a few of my patients, and it is really new test that they do the genetic testing of the DNA which has an H infection. Whatever it is, infection of HPV which has resulted into pre-invasive conditions. It is a DNA ploidy test, and it's a new test, but it's a new thing, and we have to do have our own data for this testing, and that new test is really helpful. Two of my patients, they're HPV positive since 2 years, but DNA ploid is negative, so I'm fearless, I'm free. You don't worry, your HPV has been transient infection. So these are the new tests which are coming in the pipeline. But now I think so we'll go for our
Yes, and Anjana ma'am, you're also doing great work.
yeah, thank you.
Thank you so much for that. We can go for post test. Sapna, people are waiting.
Yes, ma'am. So everybody can scan this to get the post test.
The questions of three MCQ, third day MCQ, the answers are the following is the true statement. All early stage serous endometrial cancers require chemotherapy. The most commonly used chemo regime in endometrial cancer is paclitaxel and carboplatin. Please move next. The best result yield non-chemo regime is rivaroxaban and prevzolinzumab. Even I cannot spell these words; they are so magic to us. Which is the following investigation is not recommended in case of postmenopausal bleeding is serum estradiol level. The endometrial thickness 4 mm is or less has a greater than 99% NPV for endometrial cancer. Next, please. Definition of recurrent candidal vulvovaginitis include all except 7 to 9 episodes of infection in 1 year. Next, please. The cause of recurrent vulvovagina include all except multiple sexual partners. Next, please. Condyloma ecuminata is caused by infection with human papilloma 6 and 11. Next, please. Genital herpes is treated with what drug? Systemic antiviral. Next, please. WHO vulvar intraepithelial neoplasia classification includes all except VIN 1, 2, and 3. Next, please. About UVIN, all the below are right except P16 negative. Next, please. DVIN treatment primary includes surgical excision. Next, please. Which artery is primary source of blood supply to the vulva is internal pudendal artery. Next. What is the most common HPV subtype associated with vulval cancer is HPV 16. Next. What is the recommended pathological margin for microinvasive vulval cancer stage A1A after surgical excision is 1 centimeter gross margin, 8 mm pathological margin. Next, please. According to the groins 2 study, what is the isolated groin node recurrence rate for patients with sentinel node micrometastasis treated with inguinal femoral radiotherapy is 1.6%. Next, please. Majority of endometrial carcinoma type 1 through which is the following molecular subtype has the best prognosis is a pole mutation. Radical 3 hysterectomy Verdheim should be done in all cases of endometrial falls. Next, please. If PET scan shows no extrauterine spread, THBO is enough. False. I think so. The questions are over. Now we can close down the session. If somebody wanted to know how do we get certificate, any team member can answer that. ICOG team.
या ICOG की तरफ से सर्टिफिकेट्स आ जाएंगे
Okay.
और रिकॉर्डिंग ICOG की वेबसाइट पे विद इन अ वीक अपलोड होगी.
Okay, fine. Now do we close down the session? Dr. Sarita is there? Yes. Dr. Bharti, you have raised your hand. Please unmute yourself. Dr. Bharti, you have please unmute yourself and you ask the question what you want to ask. She has raised her hand, but yes, Dr. Bharti.
Yeah, good evening, ma'am. So, thanks for the wonderful session, wonderful teaching. And I had one query yesterday about the role of HPV testing. I don't know whether I can ask it here now.
Yes, definitely. You can carry on. No issue.
So I was just wondering, when we are doing HPV testing, India is like, we are trying to find out, trying to prepare our own kits for HPV testing and go ahead with the HPV testing.
Mm.
The problem is that even after the HPV testing, if it is positive,
Mm.
then we go on for another test, whether it is 16, 18 positive. Is it going to be cost effective? What is your opinion? And even after, if it is positive, still we will have to go in for either colposcopy or VIA. I mean, is it suitable for Indian setting?
So the fact is, one, you have to understand that both HPV testing and cytology both are different methods of testing. When you do a
Yeah.
cytology, you are screening the cervix to see the abnormality. HPV, you are testing the virus, okay? Whatever
Hmm.
testing you are done, there are two methods of doing. One is a simple method, PCR method. They only will say that you are infected, the patient is infected with HPV, okay?
Hmm.
And one is genotyping. You need not do the both. If there is a high risk HPV positive, you can straight away go for colposcopy and treatment. Okay. You need not add some test. These in India, there is a different protocol. We all HPV positive. Why we want to do HPV positive testing? Because the sensitivity and pickup is very good compared to pap smear. And that's why the WHO is now for moving forward for HPV testing, because pickup rate is more. If you are positive, you go for colposcopy and treat the same way you do for a cytology, same thing. But you can combine, there is no wrong in that, and cost effective, the things are now coming down. See, HPV testing, that cost is coming down, it is around 2,000, 3,000. Even if you see LBC in the private setup, it is around 1,200. So the cost is for private sector is not a cost, but for government sectors, HPV testing, if it is becoming a government sector, definitely, if the testing keeps on picking up, the rate cost will definitely come down. So near future things will change, but HPV testing is more preferable than cytology because it picks up more infection and we can find out which are the high risk group. Instead of doing cytology for everyone, you do an HPV, find out which are the high risk and you treat them. Only need to follow them only. HPV negative, these people are safe. So that is the motto. There's a different protocols and different,
Protocol.
we can say, for management of these patients. Okay. Two
I
different
get it.
pathways, two different things are there. You don't have to
Thank
mix
you, ma'am.
cytology, HPV, you don't mix it, but they're two different thing of managing these patients. Women with HPV.
I get it. Thank you, ma'am. So
Yeah.
it is basically because of the higher sensitivity that we want to do HPV.
Yes, yes. And it reduces more, HPV detects more pre-cancer condition, and HPV is a treatment. The study was done from India. It prevented more death from cancers, then VIA, and then pap smear. So HPV has become a now new norm for testing for cervical cancer.
So even in India, we hopefully we will be able to afford HPV at like community level.
Yes, yes. Community level, they are coming up with point of care test, which will be like a small, kit with doing a pregnancy test. You do it and you get it. No, this is a red dot. Oh, she's an HPV positive, center to higher center for management.
I get it.
Is it
Thank you.
available, this point of care test? Is it available?
Madam, it is still going. It's still going on. I think so. AIMS, they are doing a study.
Yeah. I just met Dr. Neeraja once in Coimbatore. She was telling there's a lot of confusion and a lot of things is there because they are asked to validate, I think, Indian, this one, no? But still it is in a very preliminary stage, she said that once. But the problem with the HPV, see, one thing is HPV test, if you do positive, negative, you can categorize the woman so that everybody you don't need to treat, screen. HPV positive woman, probably you have to, again, you have a lot of strains. Nowadays, if you get this strains, you get 58 positive, 33 positive. Are we doing everybody colposcopy now? See, that's one thing. Otherwise, 16, 18, you do colposcopy. Other strains, probably, you do only cytology, they say.
Cytology and follow.
I had recently one girl, young girl from Delhi. She has come down here and we did it. She's 58 positive. She came down to me. I said, there's no need, probably protocol wise. You can know, but she was insisting on. When I did a colposcopy, it was biopsy. I've done it to CIN3 for her. So how do we, and most of the thing in the villages now, I have started for the last 1 year, I have started HPV DNA. in association with Indian Cancer Society. They have an MOU with me and we are doing it. And most of the people positive 16, 18, all of them are colposcopy negative.
Yes.
So these are all the things which you have. As the question asked is whether we can afford. Right now, for a screening, we can't afford, but yes, in a private and individual patients who can afford, definitely we do HPV DNA. But the problem is this now I am facing. 500 people we have done HPV DNA, in that 90 were positive. All 16, 18 and others, it's a carcinose, they give like. All of them, when I'm trying to do colposcopy, most of them are negative, except 4 of them CIN3. Others are negative. Now, can I keep these people under surveillance with HPV villagers? It's so difficult for them to bring them.
Yes,
for
ma'am.
screening. And I can't leave them saying that they are 16 and 18 positive. Now, how do I convince them? They are not willing to come for colposcopy also. It's a tough time I am having in the villages now. So there are practical problems we do have. But anyway.
Ma'am, one more question on the same line. So in Chandigarh, I'm from Government Medical College, Chandigarh. So in Chandigarh, whenever we don't have the HPV test in the hospital. If I have to ask a patient to get it done, they will get it done from some lab where we are not sure whether they are doing COBAS or which test are they applying. So I'm not even sure of the authenticity of the test, whether it is really valid or not.
Yes, that is the other thing is the problem, because unnecessarily lot of tests and lot of local people are doing it now. And in that, positivity is also a concern, negativity is also equally a concern. So there are a lot of, in between we have gray zones for us to apply universally HPV DNA testing, I think. We need to be very
Same
cautious.
thing happens for cytology also. There are so many people are doing pap smear cytology. We even don't know whether it is a proper thing or a cytopathology.
Definitely.
Same thing
That's
are
the
there.
reason why cytology is given up. No, Anjana. So that they said
Yes.
HPV DNA. See, now HPV DNA, she was only talking about DNA haploidy. See, we said HPV DNA, after that positive, you do CIN2. Then what do you do? P6 and K67, we said. Now, one more step, we are going DNA haploidy. HPV DNA you do, then go for DNA haploidy. That means to say that no test is perfect.
Perfect, yes.
No test
Anjana ma'am,
can
can I
tell
make
you
a
whether
comment?
yeah, please.
Anjana ma'am, this is Dr. Anita
Yes, yes.
Rajoria from Delhi.
Yes.
Ma'am,
Yes,
I must congratulate Sundari ma'am for that wonderful presentation. I can't stop myself, ma'am, congratulating you. It was wonderful.
Thank you.
I just want to add one comment, ma'am, because this, regarding vulvovaginal candidiasis, it was time and again highlighted role of sexual partners and sexual contacts. But for postgraduates, they must remember that it is not a sexually transmitted infection.
disease.
It is never classified into STIs. So they must not go with this impression. It may, increase the probability or, chance of infection, sexual encounter, but it is never a
increases the
STI.
possibility.
Yeah, thank you, ma'am. I just wanted to, they should not go with this impression that.
Thank
it
you.
is-
Thanks a
Thank you
lot.
so much, ma'am. Lovely interacting with you.
Thank you.
Thank you, ma'am. Thank you for the wonderful session.
I think so now we close down our session. And I thank all the organizers, especially from the Foxy, all the office bearer and the ICOG for giving me an opportunity to be as a coordinator and to coordinate with everything. It is one type of, very nice in communication with people, to know many people, and it was a wonderful thing. And I want to thank all my panelists, all my moderator, all what we can say, my MOCs, all the faculties, all my teacher for this wonderful session. And I want to thank Dr. Parul Kotrawala the most, because he was the person who made me a coordinator for this. And when you do coordination, you even read along, you meet people, and it is a wonderful experience. So I want to thank everyone. And I think so now we will end our session. Dr. Varsha, you want to say anything?
No, I would specially like to thank Dr. Surya ma'am for her expert suggestions, and Dr. Mandakini Meg her blessings. And of course, Dr. Sarita Bhalerao, she's not there, but for her, she worked very hard. And of course, you, who was the main, backbone behind today's webinar. So, and this is a wonderful learning program, ICOG Foxy certificate course on oncology. For the regular gynecologists, it has been a very welcome and knowledgeable experience, I'm sure. So that's about it.
Okay. Thank you, everyone. Now we will close the session. Thank you.
Thank you and congrats, Sanchana, for
Thank you, ma'am. Thank you.
organizing.
Ma'am, I've learned
everything.
many things from you, from Volo. Thank you.
Don't say that. Really, you have done a wonderful job, I tell you. Hearty congrats.
Thank you, ma'am.
Okay. Shall we log out?